Good evening, all the participants, as well as many guests who have accepted our invitation and joining the pre-conference course today, pre-conference presentations today. Thank you so much for coming in. Give us a couple of minutes. We have our judges ready. Judges are also online. They are here. The rules are going to be announced immediately, and we are going to start at the earliest. Dr. Joe?
Yes, sir.
Make sure you verify with the list and see the UG poster, code numbers, and if you know 1 to 5 is already in here, we don't have to waste any time. Fine?
Sure, sir.
Just keep checking. 1 to 5 is there.
Right.
Or maybe 1 to 10. There are lots in, so I'm sure they will be there. Yeah.
Sure, sir.
All right. So once again, good evening to all the candidates from this part of India, Kerala, and those who are already with online dentistry. Thanks a lot for supporting us for the last almost 9-10 months at this point of time. Right from the lockdown time, we started this. As a matter of fact, one day before the lockdown, we started it March 23rd, and March 24th was the national lockdown declared by Government of India. So we had this plan much before the lockdown, but it somehow happened during lockdown. From there, no looking back, no stopping, continuous webinars, 340 or so webinars, and then now ending 2020 with hope and prayer for 2021. We decided to end 2020 with a good note. We decided to end 2020 with a conference for all the dentists, dental students, you name it, 100% free. And guys, the registrations has crossed 8,900 as of today, which I feel is bigger than any platform conferences you think of. Of course, other than IDS, Cologne, EDAC, Dubai, Greater New York, there are 3 or 4 conferences above it. Let me tell you guys, there is nothing above it. More than 9,000 candidates registered. It's a huge show. We are talking about other conferences having 1,000 people max, 1,500 max. Thanks for the support. Thanks for see. One reason it's because it's virtual, it's online. Everybody can be in the comforts of their own home. But there are advantages of being online. That is what being utilized all these 9 months. I don't think any conference you go, you will be presenting a paper with more than 10 people listening to you. That 10 people will be the next 10 people ready to present, and that's all. Nobody else will be there listening to you. I bet you on that. I was chairing multiple sessions last 10, 12 years. I felt really sad for the students because hardly 10 people are there to listen. Things are changing. That's because it's virtual. Things are changing. This platform, you will be heard by already 50 odd people there, and YouTube Live also started. I'm sure that will also have a big count there. And most importantly, judges from all over the world. Ajman University Professor Sir is already here before you guys. He's here. Thank you so much, Dr. Sir. Dr. Vidagran Shetty Sir for coming in, and Dr. Veena. All are here. All the judges are here. We have no delay. We are going to start at the earliest. With that, I just have to tell a couple of rules here. When all the participants has to have their video switched on, number 1. Number 2, the moment your time comes, when you know it's your time next, you have to immediately share your screen, make sure your first slide is visible, and talk out, am I audible? Just talk out, am I audible? Can I start? Then one of us will say, you are audible, slide is clear, you can start. The moment we say you can start, the timer is on. After that, no more asking again, am I audible? Is the slide clear? Nothing. You are starting right there when we say start. That's it. With these words, I think I should give it over to Dr. Jobby Peter, Head of the Department, Pediatric Dentistry, Malabar Dental College, Kerala. Head of Academics, Online Dentistry, the backbone of online dentistry, Dr. Joby Beta. It's yours.
Thank you, Dr. Binu. So welcome you all to this pre-conference, and respected judges, all the participants. Thank you so much for coming on time. We opened up in the meeting in 8 o'clock. We could see people are in the waiting room, and we discussed with them, sir, why are you come so early? Sir, there will be a big rush. That's why we want to come first. So they were standing in the waiting area from morning 8:39 onwards. So let's start the pre-conference. Online dentistry, as you all know, it's a firm dedicated for dental education. Dr. Binu has clearly told our aim to redefine dental education and reach all the fraternity in a whichever way that we can go. So today, first session of the pre-conference is UG poster presentation. For this, we had around total around 90 to 95 entries we had from our judges scrutinized it thoroughly, and we selected the best 20, and you will be presenting it now, the lucky 20. All the entries were good. So the panel of judges, so the entire conference goes from today onwards. That's a pre-conference followed by 11, 12, 13. Do not miss. There are experts in all fraternities coming, and they are going to highlight their skills and their knowledge sharing there. So from today onwards, we are starting that. So about the poster, today's expert panel of the judge, Sir Raghavendra Shetty sir, he was actually a great motivator, supporter of online dentistry from the beginning. Sir has finished his MDS, FAG and PhD, and he has got lots of degrees there. And now currently he's working as an assistant professor and specialist of pediatric dentistry, College of Dentistry, Ajman University. Thank you so much, sir. It was a short time. In this short time, you accepted and you offered that you tell Joby I will be there, and you were on time. Thank you so much for coming in at the right time, sir. I hope you are safe and sound in your respective place. Then we have Dr. Veena Arali. Madam is the professor and head of the department, GSL Dental College and Hospital, Rajmundry, Andhra Pradesh. And she is also currently working as a chief pediatric dental consultant at People's Hospital, Bangalore. She's very specialized in managing child with disabilities under general anesthesia and conscious sedation. Thank you so much, ma'am, for coming in at the right time. Then we have two more judges. One is Dr. Sanjit Paul. He is also pediatric dentist practicing in Greater Noida. And we have Dr. Abhishek Soni, again, another pediatric dentist from Pune. So this panel of judges are going to evaluate today's presentation, and they are going to pick the best 5, and the result will be announced soon. Thank you so much. Over to the sessions. You can start the first roll number onwards, the test number onwards. You can start. Dr. Joe, are you there?
Yes, I am, sir.
I'm stopping my presentation. Fine.
Yes. Judges, please note, it is chest number DB1, starting the screen share. Chest number DB1, could you please unmute yourself? Yes.
Good evening, sir.
Good evening.
Can I share? Can I share?
Yes, you can start your screen share, doctor.
Okay. Is it visible, sir?
Yes, it is, doctor. And your time starts now.
A warm welcome to everyone. I hope all of them stay healthy in their respective places. Today, I'm here to talk about LIAM, Light Image Analysis Module, a boon in the field of salivary diagnosis. LIAM is a portable design module scan using verified technology. Verify technology uses immunochromatographic test strips to provide quick results in the field itself or point of case location. It mainly focuses on the combination of quick and well standardized collection of saliva along with efficiency delivery of results. Now we'll move to the procedure. Do not eat, drink, or have any oral hygiene products before the collection of sample. Plug in and start the LIM device. Set date and time. Ensure Super SAL extra device is oriented horizontally and collection is done. As saliva wakes up the pad can be moved into the mouth fully saturated. Once the sample is collected for 1 minute, place the absorbent pad in the compression tube. In an upright position, slowly push the plunker downward at a rate 2 to 3 drops per second to transfer the saliva into the Eppendorf tube. Once the sample has been expressed successfully, the compression tube from the Eppendorf tube and invert it so that we get a homogeneous mixture. A disposable pipette is used to transfer the filtered saliva from the Eppendorf tube. Observe the lateral flow strips of the Verify cartridge when the fluid is detected in the strips. Now we can move to the experimental result. When 20 minutes has elapsed, insert Verify cartridge fully into the LIM device and flush with outer wall of the device. LIM take a few seconds to calculate and the result is given in ng per ml. We can also navigate the result by going to the settings menu and selecting to pair. Ensure that the device and the other devices have a Bluetooth enabled in it. It is also very advantageous and also has many uses. I would like to conclude by saying this is a simple hassle-free procedure which can be considered good as it can be used in remote areas where equipments are not more easily accessible. Thank you.
Thank you, Doctor. Judges, it is now a question answer session for the next 1 minute.
Has it been used in any of the oral diseases?
Yes,
Any research
yes,
has been done?
yes, ma'am. Since LIM is used to diagnose the saliva, for example, in oral cancer, when we diagnose saliva, the transferrin level is more. And also in the case of periodontitis disease or periodontal diseases, hydroxychloroquine, peroxidases and calcium level is also more when compared to the normal patients.
Good presentation here.
Thank you, ma'am.
So, thank you, doctors. You can stop your screen share, Dr. DB1. Up next, we have DB02. Number DB02, please unmute yourself. You can start your screen share.
Yeah.
Yes.
Is my screen visible?
Yes, it is, doctor.
Shall I start?
Yes, you can start now.
Okay. A very warm good evening to all. Today, I will be sharing a few information about a new technology, which is the nanosono technology. It is an innovative anti-cancer therapeutic approach. As all we know that cancer has become the first killer of human health, and more researchers are attracted towards like anti-cancer therapy. At current stage, 4 main methods: surgery, chemo, radio, immunotherapy are clinically applied. Every treatment has its own kind of limitation. Likewise, surgery has limitations like clearing in the cancer cells, and chemo and radiotherapy affects the normal tissues also. Immunotherapy is an expensive and it causes cytokine storm. Therefore, finding an effective, secure, and low-cost treatment becomes extremely urgent to cure the cancer. Here comes a new technology, which is the SDT, sonodynamic therapy. It is a combination of ultrasound, oxygen, and sonosensitizer, which results in the generation of reactive oxygen species, which ultimately leads to the cell death. The mechanism of this type is, it includes intravenous injection of the nanoparticles followed by the ultrasound treatment, and then it results in the generation of ROA species and the activation of immune response, which results in the destruction of blood vessel to the cancer tissues. At the molecular level, the ultrasound treatment results in the formation of cavitation bubbles, which ultimately results in the activation of sonosensitizer from its activated state to the ground state. While returning from its excited state, it releases energy. Which results in the production of which combines with the tissue oxygen and form the reactive oxygen species, which results in the activation of mitochondrial dependent cell apoptosis. This results in the release of cytokine, which activates the caspase pathway, which ultimately leads to the cell apoptosis. Various preclinical studies were conducted using different sonosensitizer in different biological models. These are some of the examples. In this, for example, 5-ALA, which is used in the malignant melanoma, produce an anti-tumor effect. It is also conducted in various clinical studies. Wang et al., he conducted 3 cases of advanced breast cancer. He has a positive outcome and reduced secondary side effects. Immune et al., which is more recently conducted in the breast cancer, he used immunotherapy combined with the sonodynamic therapy. He has a dramatic improvements in the patient symptoms. Why nanoparticles? Because it improves the pharmacological properties, extend the blood circulation time, and improve the biocompatibility and biodistribution. And the selectivity towards the diseased tissue is also higher. Advantages of this are, now it is non-invasive, strong penetration, good patient compliance, and high precision. The disadvantages are specific mechanism of STT is not clear, sensitizer selectivity, and difficulty in the cavitation generation. This technique has the potential to cure the cancer at which the current treatments fail.
See, she lost the connection.
Okay. This technique has the potential to cure the cancer at which the current treatment fail and be non-invasive and result in the limited side effects. These limitations can be overcome by hello.
Yes, go ahead. You are
My
touched
plan. Okay. Hello.
Yes, go ahead, doctor.
Yeah, my plan of action is to develop a new sensitizer by binding them to the antibodies to target the tumor cells. This therapy will bring a revolution in the anti-cancer treatment. Thank you.
Thank you, Doctor. Raghavendra, sir.
Yeah, nice presentation. I think in between you lost audio. Yeah. How about you control about the target cells? You told it will select and hit the target cells. What about the normal cells?
We will have a specific modification to the nanoparticle so that it bind only to the cancer cells, not to the normal cells.
Okay, through the receptor.
Yeah.
Okay. Thank you.
Ma'am, you have any questions, ma'am?
Sir. No, sir.
Yeah.
Thank you, Doctor.
Thank you.
Judges, please note number DB03 on screen share.
So is my screen visible? So is my screen visible, sir?
Yes.
So can I start?
Yes, your time starts now.
Nothing is more expensive than a missed opportunity. So I would like to use this opportunity to present my innovative approach towards improving the oral health for the welfare of the patients. Futuristic therapy for the disease of the disease. You might wonder what is disease of the disease. It's nothing but oral candidiasis. We as dentists encounter oral candidiasis, that too mostly the immunocompromised patients. Here I've listed out different types of candidiasis and their variants also. For all these types of candidiasis, conventional pharmacological therapies like mouthwash, mouth paint, oral gel, troches, and tablets are prescribed. But the main drawback for all these conventional therapies are its incapability of maintaining the salivary concentration for a prolonged period of time. This is all about the background, and now comes my idea. I suggest using an oral bio patch to treat oral candidiasis, which will adhere to the buccal mucosa to the adhesive layer present in the patch. It provides a localized effect for a prolonged period of time with reduced side effects and improved bioavailability. For this oral bio patch, I've chosen fluconazole to be incorporated in the patch. Why fluconazole? It's because fluconazole is proved to be one of the best drugs in many latest clinical trials, which has better penetration, predictable absorption, better patient compliance, less toxicity, and comparatively less cost. But it also has a drawback, that is its resistance. So I have a plan for that too. To overcome the resistance, we can add doxycycline along with that. So what it will do? I've shown the mechanism over the right top corner. Here, red dots represent the fluconazole and green dot represent the calcium. When fluconazole is given alone, there is increased efflux of fluconazole. Drug hasn't gone inside. That is the resistance. But when fluconazole and doxycycline are given together, there is decreased efflux of fluconazole and increased calcium concentration inside the cell, which results in fungicidal effect. One more advantage in this combination therapy is MAC value of fluconazole is absolutely reduced. The other mucoadhesives that are under clinical trials for oral candidiasis are, one is tetracycline and carvacrol. Tetracycline is an antibiotic and carvacrol is an antibacterial. Many studies have suggested that antibiotic therapy itself induces candidiasis through secondary colonization. Then clotrimazole and quercetin and miconazole and urea. In the Assaults group of drugs, fluconazole is proved to be the best drug. So it's more superior than clotrimazole and miconazole. Moreover, miconazole is expensive too. So I suggest that fluconazole and doxycycline are the best combination therapies that can be used as an oral biopatch to treat oral candidiasis. At last, my plan is fluconazole and doxycycline could be made into nanoparticles and coated with chitosan, which has good mucoadhesive properties, and it makes the patch a biodegradable and a biocompatible one. Finally, the trials are yet to be started, but I strongly believe that such an oral biopatch will give a revolution in the treatment of oral candidiasis. I hope my innovative idea will be supported. Thank you so much.
Thank you, Doctor. Judges, please note that was registration number 03. Judges, you can ask your questions. Ma'am?
What are the challenges you think you will encounter with this oral biopatch?
Ma'am, wettability, ma'am, because saliva, we are actually in use transferable patches are only available. Maybe if it is inside the mucosa, means the wettability, the adhesive nature may be a very big challenge. So I think that that could be managed in the mucosa layer. If the adhesiveness is the main challenge.
Do you have an idea how these patches are prepared?
No, ma'am, not yet. First, I have to proceed with the in vitro studies, and then only I have to proceed with the in vivo. So I have, I'm not aware about it.
Thank you, ma'am. Moving on, we have DB04.
So am I audible?
Yes, you are, Doctor. You can start your screen share.
Yes, sir.
Judges, please note, this is DB04. Your time starts now.
Very good afternoon, everyone. The topic of my presentation is dentistry during pregnancy. The aim is to review some of the physiological changes and oral pathologies which are associated with pregnancy and to identify the safest time for dental treatment. The major dental concerns during pregnancy are dental caries, as recurrent vomiting becomes very common during pregnancy, so it creates an acidic environment in the oral cavity, which makes teeth prone to caries. Pregnancy gingivitis is characterized by inflamed and redness and swollen gums. The gingivitis is the result of the increased circulating level of progesterone and its effect on the microvasculature. Excessive gingivitis may also result in tooth mobility. Recent advances have shown that endo diseases have their effect on the preterm labor and low birth weight of the infant, as the inflamed periodontal tissue produces significant amount of cytokines like interleukin-1 beta prostaglandins, which have their systemic effect. As we know that pregnancy is a dynamic physiological state leading to several transient changes in the body, including the oral cavity as well. The cardiac output is increased by 30 to 50%. The functional residual capacity is decreased by 20% as the gravid uterus pushes the lung cavity. The physiological anemia occurs due to increased plasma volume, and high blood sugar level is also observed. When it comes to the positioning of pregnant lady on the dental chair, the ideal position is left lateral decubitus position, as in supine position, supine hypotensive syndrome may occur. So the results are amalgam releases mercury which have shown congenital malformations. The fetus is susceptible to radiations, and we should use lead aprons, and minimum frequency of radiation should be observed. The drugs which are used are tetracycline. Tetracycline should be avoided as it inhibits the bone formation and also result in staining. The other drugs which are good are amoxicillin, penicillin, and some other drugs which are contraindicated is thalidomide, as it causes amelia and phocomelia, which is the absence of limbs in the newborn. So I would like to conclude that caries and gingivitis, these are the two main things which occur during pregnancy. Pregnancy should not be considered the only reason to defer the required dental treatment, as the second trimester is the ideal for the dental treatment to be carried out. Thank you, everyone. Thank you, Dentistry Beyond 2020, to provide me a stage to express my views. Thank you.
Thank you, Doctor. Judges, please note that was DB04. The judges can now ask questions. Raghavendra, sir.
Fine, it was self-explanatory.
Okay. Okay, sir. Moving on, we have DB05. Number DB05, please unmute yourself and start your screen share. And your time starts now.
Am I audible?
Yes, you are, Doctor.
Good afternoon, everyone. I'm here to discuss about the topic pulpal diseases and diagnosis. As we all know, pulp is the principal source of pain in the oral cavity, and most people come to the clinic with the principal sign of toothache. And it is evident to what Shakespeare said, for there was never yet a philosopher who could endure the toothache patiently. Now coming to the few causes, a wide range of causes which lead to different pulpal pathologies, that is physical, chemical, and bacterial. A normal pulp, when exposure to a noxious stimuli, leads to a condition called reversible pulpitis. In turn, leads to irreversible pulpitis. If left untreated at this stage, it can lead to any one of the four following clinical conditions, and ultimately to necrosed pulp, that is pulpal necrosis, that is the death of the pulp. At times, even without any external stimuli, due to the degenerative changes in the old age, we can see calcifications in the pulpal chamber as well as in the root canals. Now, as we know about the different pulpal pathologies, let us know about the diagnostic aids to identify them. Out of them, we have visual inspection also, through which we can tell visually the pulpal pathology involved. That is, pinkish discoloration of the tooth in the case of internal resorption is due to the granulation tissue, and whereas a dark color discoloration of the tooth is due to the necrosed pulp in the case of pulpal necrosis. As we can see here, the diagnostic aids like heat test cavity, cold test, thermal test, and all are based on the neural sensibility, but they don't detect the blood flow within the pulp. So as to compensate for this, newer recent advances have come up, like laser Doppler flowmetry, pulp oximetry, which measures the oxygen saturation, and it is used in the case of traumatic injuries to measure the oxygen saturation, and trans illumination in the case of pulpless teeth, which is a developmental defect. And we have detection of interleukin beta 1 for resorption cases like internal and external resorption. In the resorption case, as we can see, osteoclastic activity is more, and it leads to resorption. And we have measurement of the surface temperature. These all aids are helpful for us to diagnose the different pulpal pathologies. Now let us know about in detail about the responses shown by the cold test. And the material most commonly used is dry ice, which has a temperature of minus 56 degrees centigrade to minus 98 degrees centigrade. And the responses range from, there are a wide range of responses because as based on the pathologies. Positive responses, negative responses are seen. And in the case of positive true response, we even depending on the duration of the response, we can have different types, that is reversible and irreversible types. And at times even we have false negative and false positive responses because of the calcifications, or a recently traumatized tooth, or a recently erupted tooth with immature apices, or pre-medications like analgesics and tranquilizers. And the most important precaution to be considered.
Thank you, doctor. The 3 minutes are up. Judges, please note that was DB05. Judges, you can ask your questions now. Ma'am.
It's a good presentation, no questions. It was all self-explanatory.
Thank you, ma'am. Moving on. Judges, please note DB07. DB07.
Yes, sir. I'm audible, sir.
Yes, you are audible, doctor. You can start your screen share.
Just a second, sir. Is the screen visible, sir?
Yes, it is, doctor.
Just a second, sir. Yeah.
Time
Can I
starts.
start, sir?
Yes, now.
Okay, sir. Enamel engineering, fiction or future of dentistry. Quoting Albert Einstein, the true sign of intelligence is not knowledge, it's the power of imagination. Good evening to one and all present in the meet. Myself, I'm here to speak a few stuffs which I felt fascinating and interesting when I read for the first time. I'm going to talk on enamel engineering, fiction or future of dentistry. Coming on to what are the enamel characteristics. Enamel, a highly complex mineralized tissue with parallel aligned filigree apatite crystals and decussating prism bundles. Inorganic content is 96%, as you all know, with small amount of fluoride and magnesium, and the organic content consists of two main proteins, that is amelogenins and non-amelogenins. And enamel cannot self-repair nor regenerate on its own. Tooth enamel, an impossible material to regenerate. Ameloblast is derived from enamel organ. After sufficient development of enamel matrix, ameloblast resolve. Culturing of ameloblast has been challenging due to highly differentiated state of secretory epithelial cells. Also, these ameloblasts lose their proliferative capacity. Enamel tissue engineering approaches. There are totally 4 approaches. The first one would be enamel synthesis using physiochemical means, using hydroxyapatite solution at a low pH, generating calcium apatite crystals. The second one would be biochemical enamel engineering by using leucine-rich amelogenin peptide forming hydroxyapatite eventually at low pH. The next one would be in situ enamel engineering using a process of remineralization through a toothpaste which uses combination of amelogenin and fluoride which generates a fluoroapatite crystals. The last one would be enamel tissue engineering, which uses cell lines such as HAT7 and LS8 cell lines for generating ameloblast responsible for enamel formation. The groundbreaking discovery of 2019, which said enamel surface mineralization and repair, that is, repair of tooth enamel by using biomimetic mineralization frontier, ensuring epitaxial growth. The technique involved was tiny clusters of calcium phosphate with diameter of 1.5 nanometer were created. Triethylamine was used to prevent clumping of these clusters. Crystalline cluster fuses and forms a tighter arrangement. Application of this cluster on human tooth with exposure to acid forms a crystalline layer with approximately 2.7 micrometer of thickness of enamel with a fish scale appearance within 48 hours. The strength and the wear resistance were similar to that of the natural enamel. In conclusion, together the host of new technologies that will not only generate the biomaterials and biotechnologies for regenerative medicine, but can also uncover unique biological mechanism that will contribute towards the generation of unique biological tissue, that is tooth enamel. Thus, it is in our hands to continue the classical, restorative and old dentistry or to make it a futurative, regenerative one. Thank you.
Thank you, doctor. Judges, please note that was DB07.
Yeah,
you may
it was
ask
an
judges.
Yeah, interesting topic.
Thank you, sir.
So you mentioned that when it comes with an acid, it will form a crystals, right?
Yeah, sir. At low pH.
Can you explain that part?
Sir, actually, what happens is when these calcium phosphate crystals are taken, sir, and then the triethylamine is used so that it prevent the clumping of that, and then it forms a tighter arrangement. When the acid is exposed, the pH falls down, and this crystalline layer like comes together, and then when they are applied on the tooth, they form a small layer of enamel within 48 hours, sir.
Okay, so you mean to say when you are doing this technology, we are supposed to lower the pH by eating sweets?
Yeah, sir. By actually, if you lower the pH, the
so this will be a blessing. Like like even though kids have the chocolates over there also carbohydrates, then it will regenerate enamel. So we don't worry.
Sir, I didn't get you, sir.
No, you mean to say like acidic environment is required?
Yeah, sir. Acidic environment is required to clump the clusters and apply it on a proper place.
Okay, thank you.
Yeah, sir. Thank you, sir.
Thank you, sir. Up next, we have registration number DB08. Please unmute yourself, doctor. You can start your screen share, doctor.
A warm good morning to all the jury members and my dear friends. First of all, I apologize because I was not able to manage the laptop. So I am presenting my presentation via phone. So while I will be sharing my screen, my video automatically will be switched off. So I am really sorry about that. And about my topic, as you all know, the pandemic COVID-19 has affected all world in different aspects. So here in this discussion, I am presenting how the COVID-19 is affected our field, that is dental field. So my topic is, just a second, I am sharing the screen right now. Is it visible to everyone?
Yes, you are visible, doctor.
All right. So, yeah. So today's presentation, my topic is dentistry amid pandemic COVID-19. I have categorized my whole presentation in 5 parts. First of all, let's have a brief introduction of coronavirus. Coronavirus disease, it is an infectious disease caused by a newly discovered coronavirus, which is spreading all across the world since December 2019. In second point, here it is the transmission of virus, coronavirus. All right. So the most important factor is aerosol, especially in dental clinics. The aerosols are the factor that transmits the coronavirus from the patient to us. So this is very, very important that we should ask to the patient about their symptoms, because if God forbid patient is having coronavirus, and if we do not take the all precautions before starting their treatment, then it can transmit from the patient to us via aerosols also. Aerosols that may be due to aerator and scaling by curating. So various different procedures from patient to us, it transmits through the aerosols, and also it will transmit from us to other patients also. So that is why symptoms are very, very important. We should ask to every patient about the symptoms. So in third point, here are the symptoms of coronavirus disease. First of all, we will ask to the patient about the very basic and very common signs and symptoms like fever, cough, and shortness of breathing. Along with that, we will ask the patient.
Time is up, doctor. Judges, please note that was DB08. You may ask your question, judges. Raghavendra sir.
Yeah, it's fine from my side. Okay, can go.
Can we move on, sir?
Yeah, you can go ahead for the next.
Judges, please note DB09. Number DB09, please unmute yourself. Yes, you can start your screen sharing.
Hello, good morning, good afternoon, everyone. Say cheese to reveal your gummy smile. Who doesn't want a Hollywood smile? Feel confident about their smile, yet some feel embarrassed and underconfident because of gummy smile. But some claim it to be attractive. Hi all, myself Sushma, BDS graduate. Today my topic for East poster is gummy smile. When you smile, the gums are visible under the upper lip. A display of more than 3 mm is called as gummy smile. Gummy smile is either due to hypermobility of upper lip, altered passive eruption, short upper lip, vertical maxillary excess, drug-induced gingival hyperplasia like dilanthin and nifedipine. Excess gummy tissue can make your teeth appear short. Gummy smile has a hereditary inclination and is more predominant in females. Gummy smile has a classification of four types. Class 1 is 25%, mild. Class 2 is moderate percent, 25 to 50%. Class 3, 50 to 100%. And class 4, which is severe, is 100% and more. Excess gummy tissue can make your teeth appear short. Gummy smile has a hereditary inclination. Distance, now the diagnosis of gummy smile. Distance between the upper tissue and the incisal edges, the lip length, differentiating between the excess gummy tissue and over eruption. Hyperactive upper lip, finding out the causes for the shorter teeth. The treatment include botulinum toxin A injection. Botox has been successful in the treatment of gummy smile. Results are not permanent, they last on an average of 6 months. The material is injected on the hyperactive muscle of the upper lip, which reduces the upward movement of the lip, resulting in smile, which is reduced. Gingivectomy or gum lift, scalpel or the laser is used to reshape the gum, and it is done under local anesthesia. Laser gingivectomy, soft tissue dental lasers such as laser diode, neodymium, yttrium doped yttrium aluminum garnet laser, erbium doped yttrium aluminum garnet laser, carbon dioxide laser offer precise, stable, painless, bloodless, accelerating the healing process. Lip repositioning surgery. The procedure changes the position of the lip related to the teeth. Orthognathic surgery. If the jaw part is the reason, this procedure will balance the upper and lower part of the teeth. It is done under general anesthesia, and the healing time is 6 to 12 weeks. Hyaluronic acid. Hyaluronic acid involves the injection of the hyaluronic acid, which restrict the movement of the upper lip. Next is the complications of Botox treatment include the pain, infection, bruising, edema, nerve palsy, and hematoma. The celebrity with gummy smile, Hollywood singer and actor.
And just change the slide. Sorry for the interruption.
Yes, sir.
Doctor, the 3 minutes are up. Thank you, Doctor. Judges, please note that was DB09. You may ask your questions, sir. Raghavendra, sir.
We'll give her 10 seconds.
Sure, sir.
Yeah, whatever. Yeah, you can conclude it. Yeah.
Okay. You've been unmuted, Doctor. You can continue speaking. DB09, please unmute yourself.
Thank you so much, sir. The celebrity with gummy smile, Hollywood singer and actor Miley Cyrus had gummy smile, which made her appear to have short, stubby teeth. And she had undergone laser treatment to sculpt and reshape the gums that gave her immense confidence to face the audience. And another example to relate is Bollywood actor Akshay Kumar with gummy smile. Thank you so much.
Thank you. Raghavendra, sir, questions? Any,
yeah.
Sir?
No, you can go to the next.
Okay. Thank you, sir. Moving on, judges, please note DB10. Number DB10, please switch on the video and start your screen share.
Greetings, everyone. So can I begin? Good evening, everyone. Am I audible?
Yes, you are, Doctor. You can start.
Thank you, sir. Greetings, everyone. Today, I'll be representing the topic immediate dentures. So what are immediate dentures and why immediate dentures? So whenever a person gets their natural teeth extracted, they have to wait for 6 to 8 weeks before a complete denture can be formed. But immediate denture offers a solution to this problem. It is constructed before and placed immediately after the extraction of natural teeth. There are two types, conventional immediate denture and interim immediate denture. The conventional immediate denture is indicated when the anterior teeth are remaining and the posterior residual ridge is healed, whereas interim immediate denture is indicated when anterior and posterior both teeth are extracted at the same time. The major difference between them is that the conventional interim immediate denture is just relined after healing period, whereas interim immediate denture is completely replaced with a definitive prosthesis. Coming to the advantages, it maintains the patient's appearance, then it acts as a bandage and splint to control bleeding. The post-operative pain is less, and most importantly, there is less resorption and better preservation of residual ridges. And the disadvantages would be try-in is not possible, then the chair side time is more, the appointment numbers are more, and the cost is usually higher than the usual. And temporary impairment of speech and mastication would be there. Now coming to the indications, it is indicated in the patients who cannot compromise their aesthetics even for a single day due to their professional commitments, like fashion models and celebrities. It is contraindicated in patients with poor health, slow healing potential, patients who are at surgical risk, like cardiac diseases, uncontrolled diabetes, then emotionally disturbed patients with psychological disorders, and uncooperative patients. Thank you for the calm and patient listening. This was all.
Thank you, doctor. Judges, please note that was DB 10. Judges, you may ask your questions. Veena, ma'am.
We can proceed further. No questions. Thank you.
Thank you, ma'am.
Moving on. Judges, please note we have DB 11. DB 11, please unmute yourself and start your screen share.
So, am I audible, sir?
Yes, you are, doctor. You can start your screen share.
Is my screen visible, sir?
Yes, it is, doctor. Your time starts now.
As it is said, no one is born perfect, and same goes with the restorative material. Good afternoon to all, and I'm going to present on the topic advances in reinforced restoration. Traditionally, more extensive restoration on vital teeth are performed by using adhesive techniques. The material of choice were gold, porcelain, and metallic ceramics. They were placed either intra or extracoronally and relied on the preparation having near parallel walls, luting cements. With the development of the new materials and technique of bonding to the vital tooth, there has been blurring of the methods used, and often restoration rely on multitude of factors for retention, which incorporates both mechanical and adhesive principle. The recent advancements are Ormosers and Silorane composites. Let's discuss in detail. Ormosers are derived organically from modified ceramics. Ormosers basically consist of three components, that is organic, inorganic, and polysiloxanes. The proportion of those components can affect the mechanical, thermal, and optical qualities of the material. In contrast to conventional composite, the Ormoser matrix is not only organic but also inorganic, and therefore the monomers get easily bended into the matrix and thus reduce the release of monomer. The upcoming advantages would be lower polymerization shrinkage and good durability. Silorane, they are made up of siloxane and oxidanes. It is hydrophobic in nature, which prevents the Streptococcus species to adhere to the restorative tooth. This product class aims to have low shrinkage and less marginal disintegration. Siloranes are polymerized by cationic reaction in contrast to the conventional composite, which cross-links via radical. The photoinitiator system is based on three components: light-absorbing camphor quinone, an electron donor, and an iodonium salt. The advantages would be longer wear resistance, light stability, and no discoloration. There is a graph showcasing the comparison of various physical properties of conventional composites and Silorane and Ormosers, which are taken from various published articles. The clinical protocols is nothing but the proper case selection, diagnosis, treatment planning. This should be followed. Design preparation with the sonic technology has been taken. One half rule can be applied by the clinician. The smallest preparation, instrument, and beveling should be done. The addition of restoration material with the finishing is done. Conclusion: vital restoration not only mechanically replaces the lost part but act as a medium through which the physical and the mechanical forces are transmitted to the tooth and investing tissue. Restoring the vital teeth with minimal sacrifice of sound tooth structure depends mainly on the adhesive that produces strong and a durable bonding to the remaining sound enamel and dentin. Thank you.
Thank you, doctor. Judges, please note that was DB11. Judges can now ask your questions. Raghavendra sir. Raghavendra sir. Arlim, Veena ma'am. Any questions, ma'am?
We have, yes, just sorry for interrupting. We have one more judge just joined now, Dr. Abhishek Soni. Can you unmute Dr. Abhishek Soni?
Absolutely, sir. Abhishek sir, you will have a pop-up right now. Please unmute yourself, sir. Abhishek sir.
Any network issue, Joe? Fine.
Yeah, so we have asked sir to unmute. Sir will be unmuting right now.
Doctor, you can stop the share, doctor. You can stop the share. We can make other person to start now. So we have three judges. One more judges will join soon.
Yes.
Thank you so much. Joe, kindly note that sir also come now.
Sure, sir. Thank you, sir. Moving on. Judges, please note. Now we have DB12. DB12, please switch on the video and share your screen. You've already been unmuted.
Joe? Dr. Joe?
Yes, sir.
Dr. Raghavendra Shetty says that he cannot unmute himself. So you want to make him a co-host, just a co-host? So it's easy.
I'll do that, sir. Sure.
Yeah, go ahead. Start.
Am I audible, sir?
Yes, you are.
Yes.
Good afternoon to one and all present here. Myself and my fellow mates are here to talk about the diagnosis of dental caries. Change the slide. Moving on to the presentation, dental caries is an irreversible microbial disease of the calcified tissue of the teeth, characterized by demineralization of the inorganic part and destruction of organic substance, which leads to cavitation. There are two methods for diagnosis. One is conventional method and another is novel method. In conventional method, first is visual inspection. In visual inspection, clean and dry teeth is examined under light source. Enamel dissolution, white spot lesion, discoloration, surface roughness, and presence of cavitations are assessed. Next is tactile sensation. Explorer and dental floss are the instruments used here. When examined with an explorer, it catches or resists removal when moderate pressure is applied. This indicates the presence of caries lesion. In case of dental floss, it gets frayed when passed through the contact area which has caries lesion. Now it's radiography. It is of great value when caries lesion is not clinically visible. Bite-Twitch radiography helps in identifying proximal and hidden caries. The final method is usage of chemical dye. Acid Dead 52 dye is used. It differentiates layers of caries dentin. The stained caries dentin can be removed by using an etcher.
Thank you, doctor. Judges, please note that was DB12. You can ask your questions. Judges, Abhishek sir.
Sir, my teammate isn't unmuted.
Okay. Were you interrupted in between?
Sorry, sir?
Was the audio interrupted in between, doctor? Are you done with the presentation, doctor?
Yes, sir, I'm done, but my teammate isn't unmuted, it seems.
Okay.
Another person is also doing.
No, she has a teammate. Teammate is not unmuted.
Correct, sir. It's Dr. Maush.
Yes, sir. Am I audible?
Yes, you are.
Yes, sir. Thank you. So under novel methods, I'll be talking about trans illumination, in which a light of longer wavelength, yellow or orange light is used. It reveals the carious lesion, cracks, stains, and the caries present below the restoration. In the case of radiograph, intraoral phosphoplates and intraoral digital sensors are used with silicon chip for better radiography. In the case of laser fluorescence, diagnodent is the device used, which is going to emit the light on the on the teeth, and it is going to indicate the presence of caries. In the case of electronic resistance and mineral content can be measured. Electrical resistance is going to be dependent on the ion concentration, saliva, and local porosity. This is going to indicate the non-cavitated lesion present on the posterior surface of the occlusal tooth. Thank you.
Thank you, Doctor.
Thank you.
Judges, please note that was DB12. Judges, you can ask the question now. Abhishek, sir. Abhishek, sir, has unmuted himself. Raghavendra, sir.
Yeah, you can go ahead with the next topic.
Okay, sir.
Yes, Joe, there is our last judge also has joined now, Dr. Sanjit Paul from Noida. He's also joined. Welcome, Dr. Sanjit. Thank you for coming. Ravindra, sir, all your friends are here, sir.
Okay, welcome. Welcome, everyone.
Yeah, hello, sir. Good to be here, and looking forward for the poster presentations.
Thank you so much, sir. Yes, Joe, you can proceed.
Thank you, sir. Moving on, judges, please note we have DB13. Number DB13, you can start
yes,
your
sir.
share and unmute yourself.
Okay. So, warm regards to one and all present here. Today, my topic is Wilcodontics, accelerated osteogenic orthodontics. So, many people jeopardize their dental health and decline orthodontic treatment because of its longer treatment time. I hope Wilcodontics could be a solution for this. Selective alveolar corticotomy, particulate bone grafting, and application of orthodontic forces. In 1990, Dr. William Wilco and Dr. Thomas Wilco discovered that the reduced mineralization of the bone is a reason behind the rapid tooth movement. So they used their knowledge of corticotomy and their observation from regional oscillatory phenomena to develop their patent periodontally accelerated osteogenic orthodontics in 1995. So let's see how it works. When the surgical wounding is, when the surgical wound in the osseous tissue resulting in striking reorganizing activity adjacent to the injury site. This is collectively called as regional acceleratory phenomena by Dr. Hadolf Frost. So when the orthodontic force is accompanied with the intentional destruction of the bone resulting in osteopenia, that is, the rich deposits of calcium are released from the bone. So this osteopenia enables the tooth to move more rapidly, resulting in greater stability with a time period of 3 to 8 months. So indications are class 1 with mild, moderate and severe crowding, class 2 which requires expansion of arch and extraction, and mild class 3 cases. Contraindications are bone loss, root damage, class 3 malocclusion, and patient who are all on NSAIDs and systemic disease. So steps involved are, after the flap is elevated, the interdental groove stopped 2 to 3 mm short of marginal crest area are made. Then the subapical horizontal corticotomy, which joining these interdental grooves are made. If the bone is thick enough, we can make solitary perforation. Then the bone should be grafted. After the recovery from the surgery, the orthodontic forces should be applied every 2 weeks. So advantages are reduced treatment time, increased bone support, and low history of relapse, less need for any extraoral appliances. Disadvantages are extra surgical cast, invasive procedure, not applicable to all cases. So I want to conclude my presentation with the thought of demanding the increase, considering the demand of increase in adult orthodontics and the patient who wants to decline the treatment time. This shortened orthodontic approach comes through the Wilcodontics could be a reliable solution. Thank you.
Thank you, Doctor. Judges, please note that was DB13. Judges may now ask the questions.
Sir, కూర్చోబెడతారు తలపై సైడ్ కూర్చోబెట్టారు
Judges, you may ask your questions now. Abhishek sir. Sanchit sir. Sanchit sir, please unmute yourself. Raghavendra sir.
Yeah. What do you mean by driftodontics? So which one will you prefer?
Sorry, sir, I couldn't hear you.
Yeah, driftodontics.
Driftodontics. Hello,
Okay.
sir.
So what is one of the challenging tasks in vilcodontics?
Vilcodontics challenge, it cannot be used in patients who are all using NSAIDs and rheumatic arthritis cases, and we can't use in class 3 malocclusion as the lower jaw is long enough, too long to the rest of the face, so it may not allow us to do the surgical procedure.
Yeah, thank you.
Thank you, sir.
Thank you, sir. Moving on, judges, please note DB14. DB14, you may start your screen share.
Sir, am I audible?
Yes, you are, doctor. You can start.
Good evening, everyone. I am DB14 and I am here to tell you all on the topic an interlink between oral and systemic health. Now, as it is said that our mouth is a window into which what's going on inside it serves as a helpful vantage point for identifying the clinical signs and symptoms of the systemic disease. The body and mouth are interlinked with each other. So taking good care of our teeth and gum can really help us live longer. Moving on to pathogenesis. Due to several factors like faulty toothbrushing, there is the accumulation of the plaque and calculus on the tooth surface which progresses to form gingivitis, which further cause destruction of the clinical attachment, and there is formation of periodontal pocket leading to periodontitis, and this further affects our systemic health. Let's move on to the effects seen on systemic health. On brain, oral inflammation is linked to Alzheimer's disease and dementia. It also increases the risk of blood clot causing stroke. On mouth, oral inflammation is linked to oral cancer as due to increased consumption of tobacco. On lungs, there is increased risk of pneumonia, bronchitis, and COPD. On heart, there is increased risk of valvular heart diseases. On kidney, there is increased risk of kidney failures, and on pancreas, there are increased chances of pancreatic cancers. During pregnancy, there are increased risk of breast cancer as well as premature births are seen. There are several steps of preventing this risk. Firstly, you need to brush your teeth twice daily, floss your teeth once daily, avoid that is complete stoppage of the habit, then eat balanced and healthy diet, visit your dentist biannually, rinse your mouth after every meal. This is very important. Then I would like to conclude by saying that our teeth and gums are a clinical visible entity which help us to know about what going inside our body. So keeping better teeth, better health. So protect both. Thank you.
Thank you, doctor. Judges, please note that was DB14. Judges, you may ask your questions.
Very well presented.
Thank you, sir.
Moving on, judges, please note DB15. DB15, please unmute yourself.
Yes, sir. I'm sharing my screen.
Yes.
So is my screen visible now?
Yes.
Am I audible?
Yes, doctor, you are.
So may I start?
Yes.
Thank you, sir. A very good evening and a warm greetings to the judges and media audience. I am here to present my e-poster on the topic Dental Home Need of the Hour. The concept of dental home is supported by the American Association of Pediatric Dentistry as well as American Dental Association as an ongoing relationship between the dentist, who is the primary dental care provider, and the patient. It includes comprehensive oral health care beginning at age 1. The dental home also enhances a dental professional's ability to provide optimal health care by visiting the dentist at 1 year of age earliest for a successful preventive care and overall treatment and healthcare as a part of an overall healthcare foundation for life. It also assures appropriate referral to dental specialist when care cannot directly be provided within the dental home. It sometimes happens that, for example, a child has landed up and it needs an interceptive to undergo interceptive orthodontics treatment. Then the licensed dentist can refer the patient to an orthodontist. In a journal named Pediatrics, a study was done in 2004 which shows that the cost of dental treatment in children who have their first dental visit before age 1 is 40% low then in the patients in those in the first 5 years for those who do not see a dentist before their first birthday. Through early professional dental care complemented with caries risk assessment, anticipatory guidance, and periodic supervision, we can also prevent early childhood caries, tooth decay if left untreated in the earlier stages of the life of a children can have serious implications for a child's long-term health and well-being. Without preventive care, the impact of tooth decay on child development can be significant. Now the question arises that how we as dentists can improve this or make a difference. The answer is by incorporating the age 1 dental visit in our dental practice and infant oral health exam into our practice, which can help prevent early childhood caries, and we can go a long way to prevent early childhood caries, assuring optimal oral health care for a lifetime. We can help parents understand the importance and need of the visit to the dentist within the 6 months of age or within the 6 months of the eruption of the first tooth or the first birthday of the child. We should also educate the parents about the need of pacifier use, when to use the pacifier, when to stop feeding practices, when to bring the child for fluoride applications, overall oral health management of the child. So thank you.
Thank you, Doctor. Judges, please note that was DB15. Judges may now ask their questions. Sanchit, sir.
Yeah, so nicely presented. I would say it was quite comprehensively prepared. Only thing I could suggest is that you could have made the poster a little bit more attractive. I know that the textual part is there, but since it's a poster, more of pictures would have really helped. But it was a good attempt. So yeah, good work done.
Thank you, sir.
Thank you, sir. Judges, please note DB16. DB16, you may now start your screen share. Please unmute yourself.
Hello, sir. Hello.
Yes, doctor.
Yes, sir. My screen is visible.
Yes, it is, doctor. Please start the screen share, doctor.
Sir, can I start?
Yes, you may start.
Good evening, everyone. Today I will be presenting on the topic stem cell, the generation of regeneration from human exfoliated deciduous tooth. As Steve Jobs correctly said that every little thing is important and it lies in our knowledge to understand its importance. This is very important for the deciduous tooth, which we just throw away, but it has the capability to save life. These stem cells are unique cells which have the unique capability to develop into any specialized tissue of the body. And the stem cells obtained from the teeth can not only convert into odontoblasts or anything related to teeth, but also to any specialized tissue of the body like the mesenchymal cells, adipocytes, chondrocytes, and so on.
Even a study from ACE World has shown that if the vital pulp is obtained from a carious tooth, it has the equal potential. And when these stem cells are combined with trisodium phosphate, it can even regenerate bone. And these stem cells are emerging today more in the treatment of nervous cells because of its reduced regenerative potential, and that these stem cells of the teeth are derived from the neural crest cells. Recent studies have shown that it can even convert into heart cells, hepatic cells, and islet Langerhans-like cells aggregates. So moving on to my poster, that the inclusive criteria for the deciduous tooth, which include the anterior tooths are more preferred with vital pulp. And what happens in the lab? How these are processed? It follows that the teeth is collected in the milk. It being the isotonic solution. Then it is put into hypertonic solution where the cells are extracted. Then it is checked for contamination, and the cells is split and is stored in two different stem cell banks. And the exclusion criteria, which includes that the posterior tooth are not preferred, and the tooth which has a gray pulp is also avoided. So what is the advantage of stem cells we have in our hand, that we can store this type of stem cells? And also the cost of storing these stem cells is much reduced than that of cord cells. And the biggest advantage is that these cells, being adult stem cells, are not subject to ethical concerns. And the disadvantages include that lack of extensive study is undertaken regarding this, and more study should be needed to come into any conclusion. Moreover, a cost in a developing country like India is also not much affordable. So I would like to conclude my presentation by a quote of by M. Fox, that if the potential of the stem cell research is realized, it would mean an end to suffering. Thank you.
Thank you, Doctor. Judges, please note that was DV16. Judges may now ask questions. Raghavendra sir. Sanchit sir.
Yeah, Dr. Abhishek is there if he has any question to ask.
Sanchit sir.
Yeah, I have a question to ask in the form that, so the poster was nicely made. I could see very nicely prepared, well researched. Only thing is, in the references you have mentioned NCBI. What is NCBI? Hello, can you hear me?
Sir. Hello, sir.
Yeah,
it's National Medical Biomedical Research.
So what is the popular name for that reference? Did you read
Research
about?
kit.
Yeah, tell me. So you read about stem cells from the human exfoliated deciduous teeth. Which all literature you referred from? Like, where did you find the literature or any articles?
So there are much widespread literature, and this research is presently going on in the International Journal of Current Research. Then even in the Nature, it is also published. It is recently published. In 2020 only, I went through the article that it was published in the Nature article about this.
So where did you find all these articles from?
Sir, in NATE, from NATE only I collected.
Yeah, so there is a protocol PubMed. So that NCBI is from PubMed, right? So when you try to put the reference, try to give the article name rather than PubMed name, because that's not the right way to do it. You should quote the exact article, Nature article, or the article you were mentioning, right? So nicely prepared. You obviously you can do better, but for the beginning, this is good. All the best. Yeah.
Thank you, sir. Dr. Abhishek, you have any question? Raghavendra sir, any question?
No.
No.
You can go ahead.
Yes.
Thank you, sir. Judges, please note DV18. DV18, please unmute yourself and start your video. Yes, you can now screen share, doctor.
Sir, am I audible?
Yes, you are, doctor, and you can
Can I
start
start?
now.
Good evening, everyone. Today I'm going to present on topic magnets in dentistry. As we all know that the use of magnet in dentistry is not new. They were used since the olden days. But in olden days, they had limitations of being bulky, toxic, and corrosive. The reason for use of magnets in dentistry is the easy fabrication, inexpensiveness, and the strong attractive forces. Under this poster, I will cover some applications of magnets in dentistry, then the newer magnetic system, that is MagFit, and the overall advantages and disadvantages of magnets used in dentistry. So under applications, magnets are used in prosthodontics and in orthodontics. In prosthodontics, they are mainly used for the purpose of retention and stability. They are used in maxillofacial prosthesis and overdentures. So as seen in this picture, this is palatal obturator connected with facial prosthesis by the magnet. So in elderly, in orbicular, in auricular prosthesis, in maxillary large and small defects, they are much helpful. Next, coming to overdentures. In overdentures, this system is known as magnetic keeper system. In this one magnet pole is embedded in the on the ridge, and the next one is embedded on the overdenture. So the main advantage of using magnetic system in overdenture is they do not transfer destroyable lateral forces to the supporting structures, and the bone support needed, it is very less. Next, it is used in orthodontic tooth movement. They are used in space closure. They are used for correction of dislocated, inclined, or rotated teeth. They are also used in eruption of impacted canine. So as shown here, this is the impacted canine, and by the force of magnet, the eruption of canine would occur. Now coming to a newer magnetic system, that is MagFit. So as I already mentioned, there were many limitations of conventional magnetic system. So which are overcome by the newer magnetic system, which are they're thin and they're easy to bend, and they're more corrosive resistant because of the use of rare earth metals like samarium and cobalt alloys. The only disadvantage of newer magnetic system is the extensive root preparation for the root cap as shown in figure. Now I'll cover overall advantages and disadvantages. So retention and stability is the main advantage, while under other advantages, automatic resetting of denture can be occurred, and soft tissue undercuts can be engaged. In disadvantages, corrosion is the main one, and loss of retention due to trapped wear debris between root and magnet occurs. So concluding my topic, there are wide range of opportunities for research in magnets in dentistry for budding dentists due to their easy fabrication and inexpensiveness. Thank you.
Thank you, doctor. Judges, please note that was DB18. Judges, you may ask your questions. Raghavendra sir.
Have you come across any cases where magnets have been used to treat?
Not in my everyday life, sir, but I have read one of the cases in orthodontics, which I have mentioned in my poster.
Okay. Yeah. Any others?
Yeah. Any particular reason to choose this topic out of all the topics?
So going through all the topics, I came across this topic because like I have never been through this topic anytime before. So it took a keen interest in this topic, and yes, then I chose it. So no particular reason.
Okay. Nicely presented. Thank you.
Thank you, sir. Judges, please note, up next, we have DB19. DB19, please start your screen share.
Okay. Sir, is it visible, sir? Slide,
yes, it is.
Is it visible?
Yes, it is. You can start the screen. Slide.
Can you, okay. Can you start?
Yes, you can, doctor.
Okay. So hi all. Today we are going to present about smile design.
The digital smile design is a multi-use conceptual tool that enhances the diagnostic vision, improve communication, and predictability throughout the treatment.
We can consider various factors, micro, macro, nano features of the extraoral and intraoral factors during digital smile design process. The component of aesthetic smile, we can first starting out the gingival senate is most apical portion of the gingival point, and this maxillary central incisor and canine is distal to the long axis of tooth, and the maxillary lateral incisor it's coincide with the long axis of tooth. And the next one is black corridor. It's a triangular space present in the maxillary anterior tooth. And the third one is incisal embrasures, is triangular gap present in the incisal edge of maxillary anterior tooth. And the fourth one is your smile curvature. It is a curvature present in the lower incisal edge of the maxillary anterior tooth. And last is proportion. It's a mathematical tool that determines the proportion of maxillary anterior tooth. According to this, maxillary central incisor is 1.6 wider than maxillary lateral incisor, and the maxillary lateral incisor is 1.6 wider than maxillary canine from front view.
So the digital smile design workflow consisting of a cross that is placed centrally on the slide, and a facial photograph with the tooth apart is placed behind the slide region. It is followed by digital Facebook. It consisting of placing a horizontal line over the interpupillar and a vertical line that passes through the chin, glabella, and nose region. It is followed by analyzing the smile and followed by smile simulation. It is finally followed by transferring the smile the cross to the intraoral region, and then it is followed by measuring the tooth proportion. It consisting of measuring the length and width of the central incisor tooth. It is then followed by measuring the tooth outline. After that, while aesthetic evaluation is done, it is then followed by a digital calibration. And finally, the transferring the cross to the cast. It is followed by drawing a horizontal line over the 6 anterior region, and the facial and dental midline is analyzed. It is followed by a diagnostic backup, try-in, and the final restoration is.
The process of digital smile design. First, we are starting with First, we are taking a pre-operative photo. Then, you can use both intraoral and extraoral scanner. The scanned images then transferred to a computer using digital smile design pro software. We can make sketches on the computer, and finally, the sketches are transferred to a cast and milling the cast. Then we can make a template. Finally, small tooth reduction process is taken down in tooth, and the laminate is placed in the tooth as final process.
So we are concluding our presentation. Thank you.
Thank you, doctors.
Hello.
Judges, please note that was DB19. Judges, you may now ask the questions. Abhishek, sir. Sanchit, sir.
Yeah, so I would say a very nice topic chosen. This is one of the most and most popular topic nowadays. So I understand you were making a poster, so you have tried to take a Google pictures. But if you can try taking pictures of your own department, or somebody has done it from somebody who know you, who you know, because those pictures actually really help. These are Google pictures, right?
Yes, sir. Yes.
Yeah. So have you seen yourself any case which is properly designed from start to finish? Like, have you seen yourself, or have you witnessed anything?
Some YouTube videos only, sir.
So YouTube videos is a different
done
thing.
anything.
Yeah, but try watching a case like this, somebody from a postgraduate department or somebody from a practitioner perspective. It will really give you more motivation to read and understand more about it.
Sure, sir. Sure, sir.
Okay, all the best. Thank you.
Thank you, sir. Thank you so much.
Thank you, sir.
Raghavendra, sir, any questions, sir?
No questions. Yeah. DB17 was missing or what?
Yes, sir.
Okay. Then fine.
Right now, we have actually completed all. Right now, the missed ones are DB06,
Yes.
DB17, and DB20.
Okay.
If you are here,
Fine.
please raise your hands. Or you can switch on the videos.
Okay.
Just help us identify.
Can you please stop the share? Can you please stop the share, DB90?
Done, sir.
Yeah. So DB06, DB17, DB20, 20. If you are here, please raise your hand or come to the chat box and let us know that you are here.
No response till now, sir.
Okay, I think then that means they have not turned up. So anyway, those who have turned up, you have not considered for the next, for the best 5. One second, I'm getting a call. Maybe just one second. Let me give. Maybe they have some net issue. I'll find out and come. Please be patient. Thank you.
Sure, sir.
Joe?
Yes, sir.
Can you unmute DB19?
DB19, sure, sir.
Yes.
I've done that, sir.
Yeah. Doctors, can you tell me what has happened? DB19?
Sir, we were DB6, we see note 6, but we couldn't connect it on
Okay,
that time.
Two participants
Okay.
are joining from the same lab.
Okay, now
Well,
you're DB6, right?
Yeah, sir.
So I am going to rename you as DB6 and you can start.
Okay, thank you, sir.
Okay, sir. Judges, please note, we have DB6.
Just please note that this is DB6, the mixed DB6. They had a net issue, so they could not join that time. Now they are doing it. You can start sharing. Yes.
Is that visible, sir?
Yes,
slide?
yes.
Thank you, sir. Can we start, sir?
Yes, you can.
Can we start?
Yes, please.
Thank you, sir. Good evening. First of all, we would like to thank you for giving us this wonderful opportunity. Our topic is mineral trioxide aggregate MTA. It's a Portland cement-based endodontic material introduced by Dr. Mahmood Tarabinjat.
Coming to the classification, based on the color, there are 2 types, gray MTA and white MTA. Tetracalcium aluminum ferrite is responsible for the gray color, and compressive strength, setting time, and particle size are more for gray MTA compared to white MTA. Coming to the manipulation, powder and nickel are taken in 3:1 ratio, and the manipulation is done on paper pad or glass slab with metal or plastic spatula, and the mix should be covered with moist and cotton pellet to avoid dehydration. A new method introduced for the placement of MTA, that is MAP system, micro-apical placement system. Coming to the setting reaction, it is a hydrophilic in nature and it sets by hydration reaction. That is, it needs moisture for setting reaction. Then coming to the properties, it has got excellent marginal adaptation and sealing ability. And because of its high pH, it has got antibacterial action. And the most important property is tissue regeneration. That is, it induces dentin, bone, and cement formation. It is osteoconductive, osteoinductive, and cementogenic material. And it helps in dentin bridge formation, and it shows no signs of solubility, and it is a biocompatible material.
Now we discuss about the clinical application. MTA has got various exciting clinical applications as it possesses several qualities required for new dental material. It can be used for pulp capping procedures, pulpotomy, pulpectomy procedures, lateral root perforation repair procedures, root resorption repair procedure, etc. Here we see a case that has been put to our Department of Endodontics with chief complaint of decay on lower post back tooth region. And we have done deep caries management using MTA. And this is a pre-operative view and this is a follow-up view. The main disadvantage of MTA include long waiting time and poor handling properties. In order to overcome this, we have got several recent advances of MTA, like micro mega MTA. It has got finer particle size and pasty consistency that makes it easy for the placement. Dual cure MTA, which is effective as traditional MTA with easy handling properties. Fast set MTA, it is also effective as traditional MTA with added advantage of quicker setting time. MTA flow is also effective as traditional MTA and it has got easy handling properties.
Thereby, we conclude that MTA is a new material that possesses numerous exciting possibilities for pulpal therapy and is one of the most versatile materials in the field of dentistry. Thank you.
Thank you, sir.
Thank you, doctors. Judges, please note that was DB6. Judges may now ask questions. Raghavendra, sir.
Yeah, have you used MTA? You showed a case report. It's good. Your presentation was good.
Thank you, sir.
Yeah, what is the challenges of using the MTA? Have you come across any difficulties while using it? Have you used MTA?
No, sir. This is done by our PGs.
Okay,
And
no
we
issues.
have borrowed it.
Yeah, no problem. For undergraduate level, you have done a good presentation.
Thank you, sir.
Thank you, sir.
Thank you.
Joe, is still DB017 is missing, right? 017 is missing, right? They have not come?
Yes. DB17 and DB20, sir.
20 is the part they're combined, I think.
The topic is oral hygiene, sir.
Yes, oral hygiene, but they have not come, right?
No, sir, no, not yet.
Fine. Okay. So, sir, we have concluded all the presentations. Thank you so much, especially the judges spending our time. Raghavendra sir, as a senior most pediatric dentist with 15 years of experience, more than that, and as an organizer of the wonderful ISPPD conference that you did, which we cannot forget. Can you please comment on your take on the today's presentations, and can you talk about them?
Yeah. Thank you very much. It is, first of all, I'd like to congratulate the team for taking so much. I know how much of effort it needs to organize, whether it's a virtual or other conferences. It takes a lot of time to organize like these events. So first of all, I'd like to congratulate you all, the entire team, for this wonderful conference, which has started from today, and it will go on till 13th of December. And as far as the poster presentation is concerned, I'm very happy. In an undergraduate level, I feel the bar and very interesting topics. So I really enjoyed sitting here for more than 1.5 hours, listening to the young budding dentist who will be our future. So I'm very happy. They have made their effort. Each and everyone have done their work. And at the end, like, we need to grade. Only in that case, don't be disappointed if you're not graded in the first fight. But everyone have done a wonderful job. It was really enjoying listening to you all.
Thank you very much, sir. Thank you very much. Dr. Joby, may I?
Yes, Bino, you can take.
Thank you very much. All the judges for your time, for your dedicated listening and your comments. It matters a lot for the budding dentists. Now we have to move on to the next session, that is the official inauguration of the pre-conference Dentistry Beyond 2020. Official inauguration with no hesitation. The moment we ask Sir Dr. I.K. Pandit sir, Dr. Raghavendra Shetty, don't leave. I.K. Pandit sir is here. You would like to listen to him. So Dr. Veena, don't leave. Dr. Sanjit, Dr. Abhishek Soni, pioneer in pediatric dentistry. I.K. Pandit sir is here. He's already online, ahead of time. Thank you so much, sir, for coming in. Principal and director of DAV Dental College for the last 13 years. And in his resume, my God, it's like a huge resume, okay? I just took some points out of it. Sir only told me, Dr. Binu, don't read the whole thing. So I've just got little points there. But some interesting points. The youngest person to take over a postgraduate dental college principal post. He did his BDS and MDS from the prestigious King George Medical College, Lucknow. And his fellowships, his degrees just goes on and on. Fellow of the Pierre Foucault Academy International, Fellow of International College of Dentistry, Associate Member of Asian Academy of Pediatric Dentistry. He has received multiple awards, multiple, right? From Rotary Club. I cannot read the whole thing here. But the things that really intrigued me is about that distinguished Pirandist award which he got. And guys, more than 100 publications in his name and 915 citation index. Believe it or not, that's not a joke, guys. We have got one of the the most respected fraternity in the whole of the country, I would say whole of the world when it comes to pediatric dentistry. That's it, Dr. I.K. Pandit, sir. I welcome you from the bottom of my heart. It's yours, sir.
Thank you, Dr. Bino, and I am really humbled the way you have introduced me. I don't think I deserve that much, and I'm really happy to see Joby and Raghavinder. Both of them are my real good friends, and we are colleagues, and we have been so together in many of the conferences, many of the occasions wherever decisions have to be made or something has to be done or discussed. So they are the pillars adding strength to our association. Indian Society of Pedodontics and Preventive Dentistry. You see, this is I think this is the first virtual conclave at such a level, international level. I think I have come for the first time, and that too going on very smoothly. I have been watching this for the last 1 week, and the different speakers have been. I heard a great lecture by Dr. Joby Peter himself. So I am really overwhelmed the way they have gone through. That is. Even in this, when most of the, I mean, globally, everyone was always finding, so what will happen to us? What is going to happen to dentistry? And how are we going to survive? And how new students are going to install faith that they have to go ahead with this. And I think this is a great opportunity by all these two young fellows who have really got a brainstorming sessions behind making this program as successful. I am really thankful that they really have done a human job, as you all know, about online dentistry conference, where in exhaustive teaching, virtual demonstration courses, which are practically oriented and adding knowledge to every learning and practicing dentist, even in this time of global pandemic. It is indeed a high quality evidence-based and contemporary education and training standards to serve patients and public. You'll be very glad to note that today, as I have been told, because you see how connected we are virtually, and I have been told that we have more than 9,000 not local registration, 9,000 international registration. At this present, there are 9,000 people internationally who are watching this seminar, watching this conclave, watching this conference going on flawlessly. And really, I officially declare this online dentistry conference, Dentistry Beyond 2020, open. I thank the brain and hard work done behind the success of this conference, and Dr. John, who is, I already told you, is a pediatric dentist, periodontist, my colleague, and Dr. Bino Abraham. I have heard Bino Abraham myself in several conferences, lectures. Preferably, we as a periodontist, our conference is incomplete without Bino's presence there, and he has taught our students, our fraternity, orthodontics in a most simplest ways, where a periodontist can intervene and can do treatment, orthodontic treatment, much comfortably as if he is doing a normal periodontic practice. So I am really thankful to both these gentlemen, and I just have this information that Dr. Monica Sharma also, who is an ENT specialist, is also with this team, and she's really making this program to go much ahead. I really am thankful, and I'm for inviting me at this program. I don't feel that I am a guest over here. I am also one of the persons who accepted such a sacred invitation, where I sensed that this program is going to be very effective, very mind-blowing, and very important for the younger as well as the people who are already in this profession, who will learn a lot from with this program. So I have seen this. They have done some practical virtual demonstrations and all. So I think this is going to be a new era, a new mind opening for our students, for our practitioners, for our teachers globally. So that how dentistry will evolve in future. I wish this conference great success. My whatever I could or can contribute, you are always welcome to involve all of us, and whatever help, anything from our side you ever want, we are ready as soldiers to help this program go successfully. Thank you very much. Thank you, Joby. Thank you, Bino, and thank you, Raghavendra, Dr. Soni. I'm not able to see him here because I'm not well versed with this system. I am trying to learn. So thank you very much. Thank you.
Nice to see you, sir. Thank you very much.
Thank you very much, sir. Really appreciate your effort in coming so early. Thank you very much. From Team Online Dentistry, an official thanks on behalf of myself and on behalf of the whole team Online Dentistry. Thank you very much, sir.
My pleasure.
So to go on with our session, Dr. Joby, you want to take over, and let's have a small commercial break here. We have commercial breaks also, sir. We have ads coming up. Can you believe that?
Yeah.
So
yeah, I saw a BMW going.
Yeah. So Dr. Pandit, sir, I would suggest that you stay for one more minute to see the amazing talents of the dentists all around the world. Amazing talents of the dentists all around the world. I've just compiled it into a small video. You want to see this, sir? This is great work by dentists all around the world. All right, sir. We had a tough time selecting out of 170 artworks which we received, 190 artworks which we received. It was not an easy job. We had judges all around the world again. A famous prosthodontist from Malaysia, Dr. Q. A very famous orthodontist from Bahrain, Dr. Arab orthodontist, Dr. Shahala Abdul Gaddafi. And around 5 local artists in around Kerala all had to sit together for hours to select whom to give a prize. And believe me, we had to select top 20. Of the top 20, 5 receives cash awards and all that. But judges were all together in one thing. We cannot stop in 5. It's much more than that. So we have decided 5 top picks and another 5 as special jury mentioned, special certificate for another 5. So we have decided on 10 this time because that is the amount of response and that's the amount of talent we saw there. So again, thanks a lot to all those who participated. All that will be presented soon, tomorrow, day after tomorrow, and then Sunday night, the winners will be declared by the celebrity themselves. They've agreed to come personally and announce the top 5. All right, sir. Thank you so much once again for staying back. We appreciate it. Thank you, sir. Yeah. Dr. Joby, you can take off.
Yes. What about the commercial break? Joe, can you put the video?
It's 5:42 now. We can have a small commercial break around 7 minutes. What do you say?
Yes, Bill.
Exactly at 5:50, we will rejoin back with the next session. That is the PG.
Sorry, UG paper.
Sorry,
UG paper.
PG paper presentation.
UG paper presentation.
UG paper presentation to be started. We have told them at 6 p.m. So they are yet to come in. Many are yet to come in. But Joe and Jobby, you want to just check who are there? We can start from 5:50 onwards, Jobby. We don't have to wait till 6. Okay, they are there. Okay.
Yeah.
And we can
Joe,
put
can you
one
share
more message in the group that they have to come. I don't think nobody expected this kind of a strictness in the time. Everything is so spot on. They may not have expected that, so that's why they are like delaying in coming in. So we can put a message in the WhatsApp group to all those selected 20 people. Let them come in. We can start at 5:50 exactly. Thank you very much, one and all. Let's have a small break. Joe, I think there's an audio issue with your thing. You want to stop your share? I'll take care of it. Here we go. Our prime sponsor agreed to give all the prices.
Binu, the sound is not there, Binu.
Javi?
Yes, Binu.
What about the other two ads, other two sponsors? Now, there's a question from Sujitra sir. What about the top 20 selected for the Dentist Got Talent competition? Yes, that's also coming up. Just wait. That's also coming up. 20 has been selected there also, and of which top 5 has been selected in that also. Everything is going on parallelly. Just be patient. It will all be announced pretty soon. Joe, you want to take care of the other two ads? And in another 4-5 minutes time, if the candidates are there, we can start.
Dr. Joy, our next participants have reached.
Yes, sir. A few are here, sir.
Okay. They are renaming, no? They are renaming to their.
Yes, sir. I'm taking care of that, sir.
Okay, fine. Okay. Judges are also just message. They are joining back very soon. Please have some more time. Please give some more time. Once the judges are there, we will be starting it soon.
Doctors, all candidates participating in the DB poster competition
Joe?
Yeah, sorry about that. My audio got scrambled. Doctors, all participants who have participated in the UG poster competition can rename themselves back to their own names. And candidates who are participating for the UG paper presentation can please raise a hand or switch on their videos.
For the next session, those people who are presenting, please switch on your videos because we need to, the judges are coming soon. Now we are going to start pretty soon. Correct, 6 p.m. we will be starting this session. And the first participant, according to the list provided, the first participant be ready to share the slides.
Candidates who are participating, please make sure you are renamed correctly to your name. If there is any query you have, please do the same in the comment section.
I think one of our judges is here, Dr. Krishnamar. Dr. Krishnamar, are you here? One of the judges has come.
Yes, yes, sir. I'm here.
Yeah.
I'm here only.
Good evening. Good evening, Dr. Krishnamar.
Good evening. Good evening. Good evening, sir.
Dr. CV sir has come. Dr. CV Bullet.
Good evening, sir.
Good evening, sir. How are you, sir?
Great going, great going.
Thank you, sir. Thank you. Just waiting for.
Good evening, Dr. Sivi.
Hi, Dr. Binu.
Thank you so much for coming in.
We're just waiting for 2 more judges to join. Dear attendees, just make sure your phone is muted and no sounds come disturbance to others. Kindly see that. Thank you. Thank you.
All candidates participating in the UG paper competition, please switch on your videos.
Hey.
Dr. Joby?
Yes, Binu.
Since we have the judges here as well as DB1 onwards here, why don't we start?
Just waiting for two more judges are to arrive, just we told them 6 o'clock, they will be waiting for
But
that.
I thought 2 are already there, no, for the first 5.
Yeah. Dr. Sivi sir, can we start?
Dr. Bindu and Dr. Sri Lakshmi is there.
They have some net issue. I think they have not joined. I think so. I'm just seeing the.
I just now called. They told they're logging in.
Okay, fine. We'll wait.
Sharp 6 o'clock we will start, sir. Another 2 minutes.
Okay, fine. So dear attendees and students, wish you all the best. We are just about to start. Once the judges are joining, we will be starting. We just had the poster presentation, wonderfully presented posters we had, and judges have already started putting the mark. By most probably by today or tomorrow, we'll come to know the winners, and it will be announced in the group, the 5 best poster. So same way, now we are going to start paper. Judges are almost joining. So please follow the instructions which is given to you. Make sure your slides, your voice, your video is visible to the judges, and try to stay on time. Timing is being clearly told you, 6 minutes of presentation. Timer will be there. Once you end at 6, you will be muted. Next 1 minute is for the judges, for them to ask question and answer session. So our inauguration is just over. Respected and honorable guest, Dr. I.K. Pandit sir, inaugurated just a few minutes back, 5:30 to 6 was 5:45 was the inauguration of the pre-conference. And now we are going to the second session of today, that is UG paper presentation.
Dr. Joby, can we start?
Yes, sir. Yes, we can, sir.
Why don't you call on DB1 and let's start. Judges are here, right, Joby?
Yes, yes.
All right. All the best.
Sri sir, are you here? Sir?
Yes, sir. We will start.
Thank you. Thank you so much, all of you. So the second session is for the paper presentation. Again, we had tremendous response from various parts of the country and around the globe, but we selected the best 20 by these judges, and they are going to present and they are going to evaluate you today. So wish you all the best. So the judges heading today under the able guidance of Dr. C.V.V. Puleth. Sir is a master in public dentistry, professor and head of the department, Malabar Dental College, Kerala. He also holds MPA in hospital administration, PG diploma, and MSc psychology. Sir is an excellent orator, trainer. You name his skill, he is a master of all. Sir even writes books. He has got 6 books under him, 3 dental books. He holded various positions in IDA, Indian Dental Association, Kerala chapter. A good motivational speaker, counselor, trainer. Sir is worth listening to Sir's talk also. And he is coming on Sunday for all undergraduates. A must attend talk for 1 hour. He is going to mesmerize you. What are you missing in your daily life? What are you missing? How are you approaching your exam? How to do it and how efficiently you can do within a limited period of time. Sir is going to lead this session. Along with Sir, we have Dr. Krishna Kumar. Sir is a pediatric dentist working as a reader in the Department of Pediatric and Preventive Dentistry, Malabar Dental College. Sir has finished his BDS from KVG Dental College, Solia, and MTS from Oxford Dental College, Bangalore. Sir has got numerous publications, and one of the postgraduate life, he has done 100 points with publications. That is his credibility. such a good academician, teacher, and welcome you to this podium of online dentistry for judging the next session. Another judge, Dr. Bintu V. Bhaskar, MDS. She's working as an assistant professor, Government Dental College, Kottayam, and graduated from GDC Trivandrum and PG from Amrita Institute of Dentistry in the field of public health dentistry. Currently, she is associated with the COVID control cell at the Medical College, Kottayam. She is a dedicated healthcare professional. Thank you so much, ma'am, for coming. When I requested her, she accepted this and coming at this time. I know you are so busy at this point of time, but still you're finding time to be with us. Thank you so much. Our last judge of today, Dr. S. Sri Lakshmi, MDS and MPA in hospital administration. Ma'am is working in Chennai, and ma'am is also a good social worker, enhancing the public, educating the public about dentistry. So thank you so much for all the judges. Now it's over to Dr. Sivi sir. We can have a word, and then we can start the session.
Good evening, one and all. Very happy to be here with you. My one and only advice is be cool, nothing to get tensed. We are here to support you. We will not put you in trouble by asking so much of questions. Nothing to worry. Be bold. Wish you all the best. Thank you very much.
Joe, you can take the stage now.
Thank you, sir. Thank you, judges. Judges, please note, we have DB01. DB01, please unmute yourself.
Yes, sir. Good evening, sir.
Good evening, doctor. You can start your screen share. Yes, you can have the first slide ready.
Yes, sir.
And
Good evening to.
Yes, now.
Sir, can I start?
Yes, you can.
Okay. Good evening to judges and all the colleagues present over here. I am DB01 presenting my topic on Radix entomolaris. Contents, abstract, introduction, etiology, case 1, 2, 3, conclusion and reference. Abstract, mandibular first molar are more prone for the anatomical malformation. The anatomic variation is the presence of extra root distolingually. The distolingual root is called radix entomolaris. It may lead to the difficulties in endodontic treatment. Caraballi in 1844 mentioned a major anatomical variant of two-rooted mandibular first molar. A third root that is present distolingually is called radix entomolaris, and the root which is placed buccally is called radix paramolaris, which was suggested by Bong. And in Indian population, it is very rare, that is 0.2 to 2 to 3%, and it is commonly seen in the Africa. Etiology is still unclear, so it may be due to the external factors during odontogenesis or atavistic gene or polygenetic system. Now case 1, a 30-year-old female patient is having a pain on her right first molar, that is 4-6, since a week. She's having a deep occlusal caries and she was having a tender on-board percussion and apical palpitation. Her diagnosis was symptomatic irreversible pulpitis, and the patient was suggested to undergo RCT. The RCT was initiated under rubber dam following local anesthesia and access opening. Pulp tissue remnants were expired from the canals using K files number 10 and 15. Tooth was cleaned and shaped by a rotatory nickel titanium pro taper files. 3% of the sodium hypochlorite and 2% of the chlorhexidine solution was made to disinfect the canals, and sodium hydroxide was used as an intracanal medication, and access opening was sealed with zinc oxide eugenol cement. 2 weeks later, the tooth was asymptomatic. The obturation was carried out by the pro-tapper gutta master cones AH plus sealer. Access opening was zinc oxide eugenol cement. Patient was scheduled for follow-up checkup. Now, case 2, female of 21-year-old. She was having a pain on swelling on her right face, and she was having a deep occlusal caries on the tooth 4-6. The tooth was very sensitive to percussion and apical palpitation, and the diagnosis was pulp necrosis, and acute alveolar abscess was made, and emergency access opening was allowed to drain, and the treatment was RCT under the rubber dam, and there was extra distal canal, and the pulp was exploited and neglected using K files number 8 and 10, and canals were irrigated using 2.5% of sodium hypoxide solution and flushed with 17% of ADTA solution to remove the smear, and canal disinfected by using the sodium hydroxide, and the patient was and after a week the tooth was asymptomatic. Gutta percha master cones was selected. Obturation was carried out with the master cones and AH plus sealer, and access opening was restored with a silver amalgam, and patient was scheduled for the regular checkup. You can see two mesial to distal canal, and this is the final result of RCT. Now case 3, a 30-year-old female patient was having a chief complaint on her left side of the face, and she was having a deep occlusal caries, and she was having both tender of percussion and apical palpitation. Diagnosis was symptomatic apical periodontitis, and RCT was recommended, and her same procedure will be repeated like in case 1 and 2. Now conclusion. Radix entomolaris. Radix entomolaris in mandibular first molar is not a frequent finding in the Indian population. However, dental clinical should be aware of the occurrence of the radix entomolaris as an anatomical variant. The detection of radix entomolaris and its through cleaning and shaping and obturation should be contribute significantly towards the success of the primary endodontic treatment. Mandibular first molar have low success rate following RCT due to the factors like mesial canal, etc. The molars have high rate of extraction and early identification of extra distal lingual with minimized complication related to the endodontic like root breakage. Reference. Thank you.
Thank you, DB01. That is a very good case report. Let me ask you one question. You assisted this case?
No, sir.
Have you seen such a case?
No, sir.
No, that is not a mistake, but very good in reporting such cases. Keep on a record of such cases in future time also. Try to publish some article. Wish you all the best.
Thank you, sir.
Thank you, Sivi sir. Moving on, judges, please note, we have DB02. DB02, you can unmute yourself and start the screen share.
So my screen is visible?
Yes, it is, doctor.
Hello and good evening, everyone. I am privileged to represent my research article today amongst this awesome gathering, filled with multitude and magnitude of knowledge and experience. Couple of research articles tickled my senses to learn more about the health hazards that we using the vibrating tools during our professional practice. Hence, my study propagated me to refine my knowledge on hand-arm vibration on dentist using ready reckoner. Serious and disabling, a disorder resulting from prolonged exposure to vibration, specifically to the hands and forearms while using vibrating tools. Who would have thought that the vibration spectra of handpieces used in dentistry can likely cause a range of permanent injuries known as hand-arm vibration syndrome? The daily vibration exposure is calculated with ready reckoner. It covers a range of vibration magnitude up to 40 meter per second square and exposure time up to 10 hours. The daily exposure limit value is the maximum amount of vibration a dentist may be exposed to on any single day. The exposure action value is the daily exposure to vibration at or above which we require a certain action to be taken to reduce the exposure. Lack of appropriate and timely diagnosis appears to be an important reason for treatment delay. Hand-arm vibration syndrome, besides being a contributing factor for carpal tunnel syndrome and other ergonomic-related disorders, can cause direct injury to the fingers and forearms, affecting the proprioception, dexterity, and grip. Therefore, this led me to study the daily exposure experienced by the dentist while using the vibrating tools during the clinical practice. The objectives to the study is to determine the magnitude of vibration transmitted per day amongst exposed to the vibrating handheld tools, to determine the association of the magnitude of vibration transmission with duration of usage, to determine the proportion of exposure action value and the exposure limit value among the dentists. A cross-sectional study was conducted among the dentists practicing in and around Bangalore, Karnataka, India. The data was collected using questionnaires and Google Forms. A purposive sampling was adopted and the sample size estimated was 92. The tool used was Ready Reckoner and chi-square test was used for the association. The profile of study participants are as follows. Age-wise distribution of the respondents was 76.1% more than or equal to 35 years. The gender-wise distribution of respondents showed 56.5% of females compared to males. Pie charts representing the daily exposure time showed 79% of the dentists to work for more than 1 hour, and aeroter, being the most common vibrating tool, was used by 74% of the dentists. 85% of them with more than or equal to 10 years of experience. 48.9% of the dentists reported presenting with some or the other health-related issues. The bar graph represents significantly more of numbness and pain, morning stiffness in the dominant hand to the non-dominant hand. This was not related to smoking or alcohol. The responses were also there for ergonomic-related, joint-related, and neuromuscular disorders, which were observed. These responses, exposed to high levels of hand-transmitted drills, raises the possibility that the dentist may be at risk for hand-arm vibration syndrome. Determining the magnitude of vibration transmitted among the dentists, 40 to 92 of the dentists work with 10 to 20 meter per second square magnitude, and 52 out of 92 dentists with 20 to 40 meter per second square. Determining the association of the magnitude vibration transmission with duration of usage, this table did not show significant difference. However, twice the exposure time, twice the number of points are observed in the Ready Reckoner. So far, the data representation, we have observed that the middle-aged dentists with more than or equal to 10 years of working experience are exposed to more than 5 meter per second square of vibration magnitude. The Ready Reckoner is calculated in average vibration magnitude values over the course of 8-hour day. Therefore, 84.8% of the dentists are likely to be at or above the limit value, which means that the immediate action is required to reduce the exposure with duration of usage. This serves as a good guide to evaluate the hand-arm vibration exposure and also offers suggestions with respect to reducing associated risk. A study was conducted by a researcher on exposure assessment and health assessment of hand-arm vibration syndrome. The study involved years of vibration, total hours of use, and magnitude vibration, but no study was conducted regarding the Ready Reckoner. Various studies were also gender biased and age biased. There is evidence that the dentists are also at risk. This can be minimized by achieving health surveillance, use of improved handpieces, etc. Although it's an ongoing process in dentistry, definitely this is a study to move on from the gaps and getting closer to those refined results for future references. Thank you.
Hello, DB02. Very happy to say that your presentation was even at the level of a PG paper presentation. Congratulations. My simple doubt is, you told gender difference can affect the result. So why you didn't consider that gender difference during your study?
So actually, I didn't specifically mention that gender was the interest, but my comparison was with the study, the study which did not work on male and female. Like that person didn't really work on the gender distribution, and my study showed females were more using the, like, as you can see in dentistry now, females are more into this profession. So my study showed that females are probably prone to this case.
Right. Please do continuous research when you join for PG. Wish you all the best.
Thank you, sir.
Thank you, CV sir. Moving on. Judges, please note, we have DB03. DB03, please unmute yourself.
Should I share the screen?
Yes, you can start sharing screen.
Is my screen visible?
Yes, it is, doctor.
Should I start?
Yes, you can start, doctor.
Greetings to all the dignitaries. Good evening, one and all present here. I am DB03. The topic of my presentation is use and application of computer and internet in dental education among the students of Nagpur city. Following are the contents I will be covering in my presentation. I would like to give a short background about my topic. In this modern era, the computer and internet has currently become the most easy accessible vehicle for extracting data. Internet is one of the foremost necessary sources of data. The information and communication technology an increasingly important tool in dental education. The internet may motivate students to undertake research activities and help them develop skills in collecting and analyzing data. So we decided to conduct such type of study in our city. The aim of the study was the assessment of use of computer and internet and its application in dental education among the students of Nagpur city. The objectives were to evaluate the computer and internet use and its application in dental education and comparison among the preclinical and clinical year students. The material and methodology. The study was approved by the Institutional Ethical Committee. A cross-section study was designed. A validated 12-item questionnaire were distributed among the first to final year BDS students of the 3 dental institutes of Nagpur city. Moving towards the result, before that, the willing students of all the 3 dental institutes were the inclusion criteria, and the students who were absent on the day of survey and the unwilling students were the exclusion criteria. There were total 744 students, in which 604 females and 140 males from the 3 dental institutes, and 395 preclinical students and 349 clinical students. 16% of the students uses internet for searching information in dentistry, 65% uses internet for studies, and 69% of preclinical and 61% of clinical students. 51% of the student uses internet for the dental textbooks, videos, animations, and literature. But at the same time, 30% of the student use it for watching videos and animations. 60% of the students prefer lecture by both PowerPoint presentation and board marker method. But whereas they were very less aware about the ebooks. 45% of them agreed that computer and internet is replacement to the conventional teaching, and at the same time they agreed that it is a good supplement to teaching. The first pictorial representation is towards the use and application of computer and internet of dental education. The second graph shows the comparison between the preclinical and clinical year students. I would like to discuss some of the points. The internet has become the world's biggest library to retrieve resources. The students can undoubtedly use these facilities as a supplementary tool for learning. The internet is friendly and cost effective, from where the required information can be accessed from anywhere without time limitation. In addition, the information on the internet is updated, which helps in updating the recent knowledge and motivates students to undertake the research activity. The limitation of my study was the questionnaire was self-reported, therefore the answers given by the students can be biased. The comparison per gender of the students could not ready to calculate as the unequal distribution of the number. The future direction of my study is the survey may be extended to grasp the various sites of internet employed by the students for the study. This leads me to the conclusion. I would like to conclude that majority of the dental student uses computer and internet for their studies. The preclinical year student angle towards the use of computer and internet was found to be more as compared to the clinical year. At the identical time, the students weren't a lot aware about the ebooks. They co-jointly preferred to read text from a book. I would also like to specify that the current teaching practice is so modified in which the faculty deliver a multimodal type of lecture by using the information technology. So the student should take the computer and internet as a supplement and not the replacement. I would like to acknowledge the Dean of the VSPM Dental College, Government Dental College, and Swarkya Dadasaheb Academic College of Nagpur City, my guide, and all the students from first to final year BDS students of the respective dental institutes for becoming the part of my survey. I would like to gladly announce that my article has been published in the Indian Journal of Multidisciplinary Dentistry. Following are my references. Thank you.
Thank you, DB03. That was really a presentation of the time of online classes. I wish all dental students utilize the internet much more for your learning, especially when the clinical practice is limited due to COVID-19. My simple question is that you could have included some more cross references of other studies conducted on same title in your discussion. Have you compared your study with any other results of any other study?
Yes,
or
sir.
have you searched? Yes.
Sir, I have compared my study with 1 to 3 already published articles. They are mentioned in my reference articles.
Okay. So this is for your information. During a paper presentation, that comparison has to be included under the title called a discussion. Okay. In your future paper presentation, just remember this. The heading discussion is meant for comparing your results with the results of other studies. Right, and one more point to add: if you want to avoid the bias of reply from the students, you could have done it as an anonymous study where there is no need for the student to reveal their name. So they will directly tell they go to Instagram more or educational websites more. Okay, right. Good presentation. Thank you. Thank you very much.
Thank you, Siv sir, for the insight. Judges, please note we have DB04. DB04, please unmute yourself and start your screen share.
Sir, can I start?
Yes, you may start.
So, good evening to one and all. So, I'm DB04, presenting on the topic waste to wealth. So, this is the production of biomaterials produced from waste. As dentists, we are committed to promote the oral health and the well-being of our patients, which unfortunately also requires the use of various materials which might be potentially harmful to the environment. Hence, it is our duty to minimize the use of these and, if possible, use alternatives. A sustainable production of such biomaterials from waste would help us to provide both quality dental care and uphold our moral obligation to do no harm. Biomaterials can be classified into 4 main categories: polymers, metals, ceramics, and natural materials. Many biomaterials have been researched for and has been used ever since. And some examples include bone, hydroxyapatite, chitin, coral, keratin, biocomposites, etc. Hydroxyapatite in composition is very similar to that of bone tissue, is highly biocompatible and used for various biomedical applications. Though the hydroxyapatite produced from various sources differ in morphology and sizes, their efficacy remains the same. Hydroxyapatite can be produced from eggshells. Aggregated and cleaned eggshells are calcinated at 900 degrees Celsius. They are broken down, milled to produce calcium phosphate. They react with phosphoric acid and the product is milled again to produce a homogeneous mixture without agglomerates. It is then calcinated at 900 degrees for 2 hours. Hydroxyapatite can also be produced from bovine bone waste. Bones are cleaned, milled, calcinated at 750 degrees Celsius and cindered into a block. In vivo and in vitro tests showed that the results were similar to that of synthetic bone. Chitosan is a natural biopolymer which is obtained mainly from the chitinous exoskeleton of marine crustaceans and also from wool. It is biocompatible, mucoadhesive, biodegradable, and non-toxic. It is used in drug delivery system, dentifrice, glass ionomersivin, antifungal drugs, and also to coat implants. Rice husk, which is an agricultural waste, is the cheapest source of silica. It can be used as an additive in ceramics, glass, composites, or silica aerogel, improving their physical properties. Eggshells can be processed to be used in dentifrice. In vivo testing was done in young permanent tooth and its efficiency was similar to that of Novamine. 30% of zirconia used by the CAD/CAM technology is wasted. So the residue is filtered and separated according to their mean particle size and can be later used for sandblasting of crowns. Similarly, eliminated titanium scraps can be recast. Though the recycled titanium contains some impurities, its mechanical properties remain largely unaltered. The residue from beer and apple juice manufacture contains large amount of cellulose and pectin respectively. In vitro study shows that they can be used as a viable alternative to other synthetic sources. Other options include glass ionomer from clamshells and soda lime silicate, gypsum products from industrial waste, and cellulose from farm starch waste. Increased generation of industrial waste is a global threat to nature. Our goal as citizens of this world must hence be to be as environment friendly as possible with minimum wastage and maximum utilization of the available resources in sustainable ways. As dentists, we can contribute to solve both economical and environmental issues by coming up with such innovative solutions. These are some of my references. And thank you.
Thank you, DB4. In this era of green dentistry, this presentation holds very much of importance. Hope you will continue your research in this field and contribute towards much betterment of our profession. I had observed, I'm sharing one of my experience. I have observed the jackfruit gum getting harder day by day. So then I thought, why can't it be used as a filling material by mixing it with silica powder or glass powder? So my friends just teased me. Later, after 12 years, in 2016, another person got a patent in developing a filling material using jackfruit gum. So that means each one who is listening to me, please think about something innovative in the field of dentistry. Let our field go again and again. My only one question to you, DB04, what inspired you to take this topic?
Sir,
or tell me.
In my clinical experience, what I saw was that there was so much materials that was used and at the same time so much was wasted. So by using the same materials which was gone to waste, or by using something cheaper like agricultural waste which is just gone to decompose, so this could be used to produce something useful producing both economical and environmental, saving environmental and economical issues at the same time. So why not go for something like this?
That's great. The only one problem which may hinder that is the more expense if not done in large scale. Hope we will find a solution soon. Thank you very much. Innovative.
Thank you, sir.
Thank you, Sevi sir. Moving on, we have DB05. DB05, please unmute yourself and start
Yes,
your screen share.
Are you able to hear me, sir?
Yes, we can hear you, but your voice is feeble.
Just a second, sir.
Yes, much better, doctor.
Yes, sir. Is my screen visible, sir?
Yes, it is, doctor.
Yes, sir. Is it in full slideshow mode, sir?
Yes, we can start now.
Yes, sir. Okay, sir. Nanorobotics, fiction or future of dentistry. As a famous quote goes, challenges make you discover things about yourself that you never really knew, and it is true for everyone in their own lives. Good evening to one and all present in the meet. Myself, I'm here to speak a few stuffs which I felt fascinating when I read it for the first time. I'm going to talk on a futuristic approach, that is nanorobotics, fiction or future of dentistry. So yeah, in introduction, nanotechnology is the science of manipulating matter, which is measured in billions of meters or in nanometers, which is a size of 2 to 3 atoms. Nanorobots are theoretical substances and microscopic devices in nanometers working at atomic, cellular, and molecular levels. Coming on to the structure of a nanorobot, the structure includes a nanocomputer which has on board, which will stock and execute the planned missions. It will process signals and communicate with other nanorobots. In next thing, the structure, again, coming on to the structure, the diameter is about 0.5 to 3 microns, and the parts of a nanorobot are camera, payload, capacitor, and the swimming tail, as you can see in the diagram. And the chief elements are carbon, sulfur, hydrogen, and oxygen, and the last one would be fluoride. Coming to the mechanism of action, the mechanism will be the powering of a nanorobot is coming by metabolizing local glucose and oxygen, and the control is by the onboard nanocomputers. The communication is by broadcast type of acoustic signaling, and the navigational network provides high accuracy and keeps the track of the devices. Now, let's see the application of nanorobots in dentistry each. The first one would be in tooth repair. Nanodentistry for tooth repair has evolved through several stages of technological development. There are totally 3 ways of tooth repair possible. The first one would be hydroxyapatite as a biomaterial for dental restoration. Hydroxyapatite particle is naturally occurring mineral form of calcium apatite. Hydroxyapatite particle is a biocompatible and also integrate with bone tissue. Hydroxyapatite particle plus polymer matrix will give an increased strength of the crystals. The second one would be dental remineralization using bioactive glass, composed of silicon dioxide and calcium oxide mainly. Form hydroxyapatite layer on the surface, which helps in better bonding ability. The third one would be zirconia nanoparticles. Zirconium, as we all know, is a polycrystalline biocompatible ceramic with high resistance and good optical properties. These nanofilled zirconium particles promote bone bonding, mineralization, and dental tissue repair. The next one would be hypersensitivity cure. Coming on to hypersensitivity cure. What does hypersensitivity means? Pain derived from exposed dentin in response to thermal, chemical, and the other tactile stimuli. Calcium fluoride is a well-known agent to treat hypersensitivity, and also beta tricalcium phosphate with fluoride helps in stronger and more acid-resistant crystal formation. The next one would be orthodontic treatment. Next, on the orthodontic treatment, what happens is they interact with the cells in the periodontium, the alveolar bone, and they interact with them and correct the malocclusion and helps in painless tooth straightening. It helps in vertical repositioning in a single dental office appointment, where orthodontic treatment takes many years. The next one would be in inducing anesthesia, and it is a painless procedure. Helps in inducing anesthesia by nanorobot, which reach the pulp via the gingival sulcus and shut down the sensation for appropriate dental treatment to be done. The next one would be in diagnosis of oral cancer. Saliva is an inexpensive and non-invasively obtained diagnostic medium. Nano-electromechanical system, oral fluid nanosensor test, and optical nanobiosensor can also be used for diagnosis of oral cancer. Next, coming on to the nanocomposite, which is one of the favorite material of everyone. Microfillers in composite and microcore materials have been long-term in use. Nanoparticles improve the compressive strength of the material, and these composites play a better balance role and helps in providing a better strength and excellent aesthetics. The second last one, that is the nanodentifrices. Nanorobotic dentifrices is delivered by mouthwashes or toothpaste. They cover the subgingival surfaces, thereby metabolizing the trapped organic matter into harmless and odorless vapors, and thus they are excreted by the body through the normal excretory systems. The last one would be nano impression materials. Nanofillers are integrated in vinyl polysiloxane impression materials and have a superior flow, hydrophilic properties, and precision surface detail reproduction. The main two potential advantages are it has a better working time and outstanding strength. So yeah, in conclusion, we must always think in the future perspective and move in the direction of it. Dental nanobots may be today somewhat fictional and will bring significant benefits in oral health, contributing and achieving painless, quick, and high precision dental treatments. So yeah, these are my references. Thank you.
Thank you, DB05.
Yes, sir.
What a confident voice you have. Congratulations, man.
Thank you,
congratulations. Very innovative topic. Yes, and let me ask you, have you done any presentation on the same topic in your institution earlier?
No, sir. Actually, I had presented it as a poster in some other competition, sir.
Oh. Any other source of information other than internet? Any articles or anything have you referred or have you seen? This is just for my information.
Sir, there are like various articles produced, which were published, sir. I think one was International Journal. These are my references, sir. One was that, sir. I don't remember exactly the article name, sir, but I have referred only the article, sir. It's like I've not seen everywhere like that.
Right. This platform, Online Dentistry, is planning to come out with a journal in the next year. Better you write a good article on the same topic and send to the authorities. There's a high chance to get published. It is coming out as an international journal. Wish you all the best.
Thank you, sir.
Wish you all the best.
Thank you, sir.
Right.
Thank you, Sivi sir. Moving on, we have DB06. DB06, please unmute yourself and start your screen share.
Good evening, sir. Is my screen visible?
Yes, it is, doctor.
Can I start?
Yes, you can, doctor.
Good evening, everyone. I'll be representing my topic, extraction in orthodontics. So in this era of selfies and social media, everyone wants a flawless smile, unaware that they might require extraction of few teeth for it. But is it really necessary? Well, starting with my topic, let's see some of the reasons that might require the extraction of tooth in orthodontics. Firstly, arch length tooth material discrepancy. They should be in harmony, but if they are not, then arch expansion and extraction would be done for that. And second is correction of sagittal interarch relationship for establishing a normal incisor molar relationship. But like class 1, if it's not in normal molar relationship, then we are supposed to extract few teeth from upper and lower both arches. For class 2, we are supposed, and division 1, we are supposed to extract few teeth from the upper arch. And for division 2, we are supposed to extract from both the arches. And for class 3, we are supposed to extract just from the lower arch. And the third is abnormal size and form of teeth, like macrodontia, severely hypoplastic teeth, or malformed teeth, and any abnormal crown morphology. And lastly, skeletal jaw malrelation. Now, depending on the choice of extraction, that depends on the amount of arch length, tooth material discrepancy, the direction and amount of jaw growth, facial profile, state and position of teeth, and age of patient. Like indications for extraction of different teeth. Like for incisors, even though it is rarely extracted, the reason because of which it will be extracted will be like for maxillary incisors, the unfavorably impacted incisor then totally blocked buccally or lingually to maintain arch symmetry, grossly carious, malformed incisor, dilaceраted incisor. And for mandibular incisor, it will be totally blocked lingually or buccally. You can see in the last two pictures that the central and lateral incisors are lingually blocked. And in the upper picture, the first picture, it is a case of macrodontia, and the second in impaction in the lower mandible. And severe arch length deficiency with fanning of lower interior could be another reason. Now coming to canines, It is extracted only if it is ectopically erupted or unfavorably impacted. You can see those cases in the OPGs next to it. And deciduous canine extracted as part of serial extraction and totally blocked buccally or lingually. The last two pictures are showing buccally blocked canines. I would like to add, like, if these reasons are not present there, then one should avoid extracting canine, as extraction of it will lead to flattening of face, altered facial balance, impossible canine guidance, and change in facial expression. Now moving on to the premolars. First premolar is most commonly extracted teeth to relieve more moderate to severe crowding and proclination. Second premolar to relieve mild crowding and proclination where anchorage loss is desirable, unfavorably impacted in open bites and if grossly decayed or has large filling. Coming to molars, first molar is extracted only if it is grossly decayed or heavily filled, or in open bites as their extraction encourages deepening of bite. And it is also extracted in coming to second molar, it is extracted to prevent third molar impaction to relieve impaction of second bicuspids. And third molars are not extracted for orthodontic purpose. It is only extracted if it is impacted or it is erupting in any other direction other than occlusal, like distally, mesially, buccally, or lingually. Now, additional factors to consider in extraction of teeth would be quality of teeth. Like if the tooth is hypoplastic, heavily filled, or carious, should generally be removed in preference to healthy teeth. And then abnormalities of tooth form, like macrodontia. Like if there is a tooth or a case of macrodontia, it should be removed because it will be unsightly and difficult to align. And lastly, it would be medical history. Now, from this study, I have concluded that extraction is not necessary in orthodontics. Some cases might require extraction of few teeth, some might require extraction of no teeth. And the poor quality tooth should be preferred first for extraction instead of a healthy tooth. Thank you for your calm and patient listening. These were some of the references that I preferred. And thank you.
Thank you, DB06. Dear participants, we have 4 judges attending all the sessions, but we have divided into 4 chief judges. So I was the chief judge for the first 5 sessions. From this session onwards till session number 10, Dr. Krishna Kumar will be leading. So I invite Dr. Krishna Kumar to give your comments on this presentation.
Thank you so much. Doctor, good presentation, Doctor. Good effort you have done. Can you please tell me why did you select this topic? Why did you select this particular topic?
Sir, I personally selected this topic because I have went through 1.8 and 2.8 extraction previously, and I'm about to get my 3.8 and 4.8 extracted as well. And sooner I'll be needed to extract my 1 premolar maybe. So because of that.
Okay. Good concept, Doctor. Good thing. So good presentation.
Thank you, sir.
Thank you, Krishnamar sir. Moving on, we have DB07. DB07, please unmute yourself and start your screen share.
Yes, sir. So, is my screen visible?
Yes, it is, Doctor.
Sir, can I start?
Yes, you can.
Okay. Mystery has always attracted us. We are very much indulged in thriller stories or web series. But clinical cases can be interesting too. We collect evidence step by step and ultimately conclude the case by saving a patient. Here, the doctor plays the role of a police and the disease as the main culprit. Good evening, everyone. Today I will be presenting such a unique case on a fungal lesion. This was a 48-year-old male patient who reported in our department with the complaint of persistent headache, pain and discomfort involving both the jaws, difficulty in opening the mouth since the last 2.5 months. He also presented with uncontrolled diabetes since last 10 years with irregular medication. In conjunction with this, he also presented with generalized weakness, weight loss, occasional fever, and, and he also reported about multiple sexual partners. The extraoral examination revealed an ulceration involving the margin of the left external nares, past discharging sinus in the left middle one-third of the face, unilateral proptosis, and yellowish appearance of the sclera, along with left mandibular lymph adenopathy. Upon intraoral examination, a past discharging sinus was found in the canine premolar region. The oral prophylaxis of the patient was also poor, with white coated tongue and a cardi white plaque type lesion on the buccal and the labial mucosa. And the ulceration was also evident over the incisive papilla with a removable slough. The radiological findings reported an accentuated bronchovascular margins and a mass in the left maxillary air sinus. Moving on with advanced imaging in the MRI scan and the CT scan revealed a hyperdense area in the left maxillary air sinus. So based on this, what could be our provisional diagnosis? It could be any neoplasm, any fungal infection, or any sexually transmitted disease. So moving further with the routine hematological findings, we found that there was an increase in neutrophil count, decrease in lymphocyte count, raised blood sugar level, and the preoperative serology for the HIV and HCV were found non-reactive. And the negative VDRL test ruled out the chance for syphilis. I would like to take the note that we have taken the necrotic tissue from the left maxillary air sinus and tested sieve stain, which came to be negative, which ruled out the chance for candidiasis. And then surgical debridement under general anesthesia was undertaken, and that debrided tissue was stained with hematoxylin and eosin stain, which revealed that there was a fibrous stroma in the connective tissue, and darkly stained ovoid bodies were also found along with chronic inflammatory cell reaction. So we could guess that it could be any fungal infection. To confirm that, we moved on with Grocott-Gomori methanamide staining as evident in the 5C, which revealed that there was branched septate hyphae and spores of Aspergillus species. So based on all this, we came to the final diagnosis of invasive aspergillosis. So to recap, why such so along with the evidence? The clinical findings are consistent with the observations reported by various authors and studies. The radiological evaluation with MRI and CT scan helped in diagnosis of this invasive case of aspergillosis by Tugsell et al. 2004. The CT scan of the present case reveals the presence of hyperintense mass occupying the left maxillary air sinus, which was very characteristic of the staph disease. And the confirmatory was the varying number of branching septate hyphae, which is unique to the Aspergillus species of fungi, which is 2 to 4 micrometer in diameter, according to Del Gutio et al. 2003. Now, talking a few about the epidemiology, the mycotic infection today is in the verge to rise globally because of the climatic change, and it is more prevalent in tropical and subtropical area. Amongst the 35 pathogenic species, the aspergillosis is caused mainly by Aspergillus fumigatus and Aspergillus flavus. Aspergillosis can be defined as a fungal disease which is caused by sensitization, colonization, and tissue invasion by the species of genus Aspergillus. Now, this hyperintense mass in the left maxillary air sinus, which is very characteristic of the staph disease, is termed as aspergilloma. The treatment include surgical debridement followed by systemic administration of antifungal therapy comprising of amphotericin B, voriconazole, posaconazole, and camphofusin. The prognosis of aspergillosis is directly related to the severity and the extent of the disease, and the treatment begins the aggressiveness of the treatment. Even with appropriate therapy, only about 1/3 of the immunocompromised patients can survive. So to conclude, this case was a deceptive and misleading cases, and the decision of the clinicians based on their knowledge plays a vital role in saving the life of a patient. I would like to acknowledge my principal and the scientific committee for providing me this platform. These were my references. Thank you.
Thank you, Doctor. Judges, please note that was DB07. Judges may now ask questions. Krishnamar sir. Krishna Kumar sir? Yes.
Good presentation from your side. Good effort you have done. I want to ask you one thing. What was the treatment plan? What you have done for the patient?
Sir, the treatment plan was after we have confirmed that this was a case of aspergillosis. After the surgical debridement, we have kept the patient for about 1 to 2 months on antifungal therapy. The drug used was amphotericin B mainly, and the patient now has fully recovered from the lesion.
Okay, fine. Okay, doctor. Yeah.
Thank you, Krishna Kumar sir. DB08, please unmute yourself. Start your screen share also.
Is it visible, sir?
You haven't started screen. You have started screen sharing, but you haven't opened the PowerPoint.
Okay. So it's showing I'm screen sharing.
You ask sharing your screen, but the PowerPoint is not shared. I want you to stop the screen share, click on the screen share again, and this time choose window instead of that particular slide.
Okay, sir. So is it visible now?
Yes, it is, doctor. You can start.
Okay, sir. Okay. So good evening, one and all. Myself, DB08. So for today, I'm just going to explain in brief about recreating lost tissues. In particular, recreating lost pulp and associated structures. Yes, it's quite interesting, isn't it? My paper is on regenerative endodontics. Now, to define regenerative endodontics, these are biologically based procedures designed to replace damaged structures, including dentin and root structures, as well as cells of pulp dentin complex. Now, we have to attain 3 goals in regenerative procedures. The first should be to eliminate the symptoms and to provide an evidence of bone healing. The second, to increase the root wall thickness and increase the root length. And the third should be to provide a positive response to pulp vitality testing. Now, it is the basic difference between a traditional and regenerative endodontic treatment. In case of an immature apex, we will go for apexification in traditional endodontics, but in regenerative, we will go for revascularization. But in mature apex, it is RCT in traditional endodontics, but in regenerative, we will go for pulp implantation, scaffold implants, stem cell therapy, etc. Now, these are the key elements in regenerative endodontics: the stem cells, scaffold, and signals or morphogens. Now, stem cells are basically the most primitive cells which can undergo multi-lineage differentiation. We are mainly concerned about 2 types of stem cells, epithelial and mesenchymal stem cells. Now, these are the fundamental properties. They are undifferentiated cells. They have long-term self-renewal and they produces progenitor cells. Now, the stem cells can be identified either from an embryo or from an adult. So based on the source, they can be classified into autologous, allogenic, and xenogenic stem cells. Now, based on the plasticity, stem cells can be further classified into totipotent, pluripotent, and multipotent stem cells. Now, dental stem cells can be identified from many sources like human exfoliated deciduous teeth, pulp, from apical part of papilla, from dental follicle, from periodontal ligament, or from bone marrow. Now, these are the basic steps involved in stem cell processing, identification, isolation, and storage. Now, the various processes include fluorescent antibody cell sorting, immunomagnetic bead selection, sieved isolation, stem cell colony cultivation, cryopreservation, magnetic freezing, etc. Now, morphogens are nothing but these are growth factors or proteins that bind to the stem cells to induce morphodifferentiation. Now, various growth factors like bone morphogenetic protein, colony stimulating factor, fibroblast growth factor, insulin-like growth factor, etc. can be used. Now, scaffold is nothing but it's an artificial structure which provides a three-dimensional support for the stem cells to undergo morphodifferentiation. So based on the origin, they can be natural or synthetic. Natural like collagen or platelet-rich plasma, fibrin. Synthetic can be polylactic acid, polyglycolic acid, etc. Now, the ideal requirements of scaffold means it should be porous, should be conductive of nutrients and other vital elements, biodegradable, biocompatible, should possess adequate strength, etc. Now, platelet-rich plasma is a commonly used scaffold where we collect blood from the patient, centrifuge it with the use of an anticoagulant, and collect the platelet-rich plasma, which is then used as a scaffold. But in platelet-rich fibrin, which is Sjogren's technique, we centrifuge the blood without using an anticoagulant, and the fibrin meshwork is used as a scaffold. Now, why platelets? Because platelets releases numerous growth factors upon degranulation, like fibroblast growth factor, platelet-derived growth factor, vascular endothelial growth factor, etc. Now, this is the basic outline of what we are doing in a regenerative endodontic treatment. First, we have to identify the missing tissue space using a radiograph. Then we have to isolate the stem cells, increase the number of stem cells, at the same time control the activity to avoid any malignant potential. Then these stem cells are seeded onto the scaffold, and this is called a construct. And this construct is then implanted into the missing tissue space. Now, these are the basic techniques that come under regenerative endodontic field, like root canal revascularization, postnatal stem cell therapy, pulp implantation, scaffold implantation, injectable scaffold delivery, three-dimensional cell printing, gene delivery, etc. Now, in root canal revascularization, we do an access opening. We remove the necrotic pulp, but we do not actually do the biomechanical preparation. Then we intentionally induce bleeding into the root canal space using a cave file and then seal it. So this is a case report where after 7-month follow-up in case of an immature young permanent tooth with wide open apex. So after 2 years, we can see this is an excellent outcome with complete closure of the apex. Now, in postnatal stem cell therapy, we isolate the stem cells from an adult. That's it. In pulp implantation, we create a pulp simulating structure in vitro and implant the same into the missing tissue space. In scaffold implantation, we take a scaffold which is seeded with the stem cells and implant it to the missing tissue space. In injectable scaffold delivery, the same as scaffold implantation, but we do the same using a syringe. Then in three-dimensional cell printing, it allows us to organize the cells wherever we want to, like fibroblast, the core, odontoblast, the periphery, etc. In gene therapy, we induce the genes to produce desired proteins. It can be used by viral or non-viral vectors. Viral vectors like retroviruses and adenoviruses, and non-viral vectors like plasmids, etc. Now, coming to my conclusion, I must say regenerative endodontics is one of the least explored and fields in dentistry. So I hope more exciting developments should come from within the field. So in order to preserve the tooth as natural as possible, which is one of the biggest advantage that regenerative dentistry offers us. So with that, I conclude my paper. These are my references. Thank you.
Thank you, DB08. Judges, please note that was DB08. Judges can now ask questions. Krishnamar sir.
Good presentation. Good literature research you have done. So can I ask you, what is the scope of regenerative endodontics? What do you think? What is the scope of regenerative endodontics?
So in regenerative endodontics, we can maintain the tooth as natural as possible. So one of the biggest advantage it offers is maintaining proprioception. And compared to the conventional root canal treatment, where even if the success rate is higher, If there is a chance to maintain the tooth as natural by recreating tissues, it will be a better option, I think. And especially in case of blunderbuss canal anatomic variants like a wide open apex, where we cannot go for a conventional root canal treatment, this regenerated option will be a much better one.
Okay, okay. Can you tell me any other methods of achieving a regenerative endodontics other than getting a scaffold?
Yes, we can go for revascularization, where we induce bleeding into the root canal space, where we stimulate the apical stem cells to come and act to produce the associated structures.
Okay, okay. Thank you, thank you.
Thank you, sir.
Thank you, doctor. Thank you, sir. Moving on, we have DB09. DB09, please unmute yourself and start your screen share.
Thank you very much, sir. I'm sharing my screen. So is my screen visible now?
Not yet. Yes, now it is, doctor. Can you switch on
I'm
your video also, doctor?
Sir, actually my webcam has malfunctioned just now. So
okay.
So can I come from my phone, or is it okay without the webcam?
You can start now, no problem.
All right. Thank you very much, sir. Greetings to all the dignitaries. I am DB09 and my topic's name is Cannabis in India, a review to assess if getting high is worth the cancer. So cannabis is a topic which has recently gained much traction in the popular media with the sudden death of a famous Indian actor. The drugs and depression discussion has finally come into the limelight. So cannabis is not cannabis is not a novel substance in India. The hemp has been used as an anesthetic before surgery in the traditional practice of Ayurvedic surgeries. Cannabis is documented in ancient scriptures to be having many health benefits. The context of cannabis in today's day and age is not very progressive and virtuous. There has been multiple levied restriction of sale and consumption of cannabis due to its global narcotics and control organizations. The debate of decriminalization of cannabis is a very hot topic now nowadays. But we will only discuss about the direct and documented detrimental effects of cannabis on the dental health and general welfare of the cannabis users. So now we know that India has been a signatory to the UN Convention of Narcotics and Psychotropic Substances, and hence it was collectively working to eradicate the non-medicinal use of cannabis within 25 years of time. So the government has introduced NDPS Act in 1985. So we know that the most drug users are from the productive age group of 18 to 35 years. So the loss in terms of human potential is incalculable. The damage to the physical, psychological, moral, and intellectual growth of the youth is very high. So the drug abuse is a major areas of concern in adolescent and young people's behavior. So one study has showed that 50% of boys, while they reach the 9th grade, have tried at least one substance of abuse nature. So the common routes of administration of cannabis is that it is known by many names in different parts of India. More commonly, it is known as hash, hashish, CBD oil, weed, and marijuana. So there are many different preparation methods for cannabis. Most common being in the form of dried leaves that are usually smoked in hand-constructed cigarettes known as joints. So here we can see a typical joint made by cannabis for their consumption. So effects of so the cannabis has 66 cannabinoids. THC, that is delta 9 tetrahydro cannabinol, is the most common and commonly known as THC. So THC is mainly responsible for producing psychotropic effects. The THC effects are elicited within few minutes and lasting for about 2 to 3 hours. So the cannabis effects are produced in multiple body systems, more profoundly in the cardiovascular and the central nervous system. The oral effects are the more important for us as dentists, because but it is noted that the researchers and dentists find it more challenging because most cannabis users are regular users of tobacco and alcohol in consumption, and it is noted that most cannabis users don't disclose their illegal habits due to the scare of being caught by the police. So, a study conducted by Schultz and Catterback suggested that cannabis users are poor in oral hygiene and they brush their teeth very less frequently. So here we can see the calculus accumulation in the teeth of a cannabis user who has smoked a joint for 3 years, 6 joints a day. And now we can see about the study conducted by Darling et al., who suggested that 66.9% of these smoker participants has shown to be having a dry mouth. So the leptin hormone, which is an important hormone in regulating appetite, a cannabis user is frequently hungry after the consumption of smoke or edibles. So this phenomenon is known as hunger pangs. So the study highlighted that a combination of multiple factors like less frequent dental visit, poor oral hygiene, high cariogenic diet due to the leads to the identification of more carious lesion, particularly on the smooth surface. So a cannabis user reports to be having 6 times more decayed surface, compared to a cigarette smoking control group. Here we can see the cannabis effects on the soft tissues of the oral cavity. Xerostomia is a very common phenomenon due to the cannabis effects on the parotid gland. So the cannabis reduces the saliva secretion, which causes it to having periodontal which causes periodontal diseases. So it is well known that cannabis requires a higher combustion temperature than tobacco. Therefore, oral tissues in cannabis smokers suffer disadvantage of being at risk of thermal injuries. The Darling et al. Suggested that cannabis smoking is higher with prevalence of leukoedema in contrast with tobacco smokers. And also candida is also very well known to be in association with cannabis smoking, and because cannabis shows immunosuppressive effects via CB2 receptors found on the immune cells. And now oral cancer is a very...
Sorry, doctor, you have been muted by the system after 6 minutes. Judges, please note that was DB09. Krishna Kumar, sir.
Good literature work you have done, doctor. You have to stick to the timings, and a good literature review you have done. Can you please tell me why did you select this topic? What was the interest behind this topic for you?
Joe, you have to unmute.
Yes.
Joe, you have to unmute him.
Yes.
Hello, am I audible, sir, now?
Yeah. Go ahead, doctor. Go ahead.
Sir, I have chosen this topic because media is commonly very involved in these subjects nowadays due to the drug effect. Am I muted, sir?
No.
Hello?
You carry on.
Yeah, because the media is commonly highlighting these topics very much nowadays. So I have chosen to see how this topic is affecting the youth of the country.
Okay, fine.
Thank you, sir.
Thank you, sir.
Moving on, we have DB10, DB10. Please unmute yourself and start your screen share.
Sir, am I audible?
Yes, you are, doctor.
Okay. So, sir, may I start?
Yes, you can, doctor. All the best.
Thank you, sir. A forensic investigator can lead to the culprit with the help of footprints. So, can a forensic odontologist lead to the culprit with the help of bite marks? Hello, everyone. Today I'm here to present my original research on the title The Application of Multi-Baseline Digital Caliper and ABFO Photometric as Qualitative and Quantitative Comparison in Forensic Odontology. My study deals with bite marks. The purpose of my study was to determine the intercanine distance in maxilla and mandible of human males and females using manual and digital techniques and reliability in day-to-day routine, as well as establishing the impact of intercanine distance in medico-legal identification. These were the armamentarium required for my study. Now here comes the study design. I took a study group of 50 subjects, including 25 males and 25 females. The age limit of 20 to 25 years was being chosen, and the subjects were being chosen on a random basis. The study was being conducted for the Haryana group of population. Then I took the impression with the help of a suitable technique and examined the bite marks with the manual and with the digital techniques. Then I got the intercanine distance readings and then statistically analyzed them with the software version number 21 of SPSS and compared my results with the other studies as well. These were the exclusion criteria of my study: abnormal overjet and overbite, subjects with orthodontic treatment. And these were the inclusion criteria of my study: normal overjet and overbite, absence of spacing or crowding. The consent form was being taken in English as well as in Hindi for those who do not understand English. Now here comes the method. First of all, I dipped a modeling wax sheet into lukewarm water so that its consistency becomes soft and it becomes easily moldable. I gave it 3 folds then. This is the first fold. Here we have our second fold. And at the end, the third fold. I also made sure that the excess of water is being removed in the rubber bowl itself. I tried to make approximately 0.5 millimeter of width on all sides uniformly over this modeling wax sheet, as you all can see over here. Then I allowed the person to sit comfortably over the chair and open her mouth. After that, I inserted this modeling wax sheet into the person's mouth, as you all can see over here. Then I allowed the person to take a bite. And that's what I got: the maxillary impression over the upper side and the mandibular impression over the lower side of the same modeling wax sheet. The perforated bite marks were being discarded, and in those cases, I repeated the procedures in order to get the perfect bite marks so that any false measurements can be eliminated. Then I did the examination with the help of the manual and digital methods. This one is the manual method, in which I use the ABFO scale number 2 in order to get the intercanine distance readings. ABFO scale number 2 stands for the American Board of Forensic Odontology scale number 2. Then, when all the tables were being tabulated, the statistics were being made by me, I took some plastic pouches and labeled them with the number and with the gender so that I can save and preserve my impression samples for any future studies ahead also. This was being done under the CDC guidelines. I preserved these impression samples very, very cautiously, as you all can see over here, and ziplocked them all at the end. Now these are the impression samples for 25 males and these are for 25 females. This is the pictorial representation of the manual method that I just explained. And this is the sample slide for my digital method. In this, I basically projected the tips of the digimatic caliper over the canine tips on the impression in order to get the intercanine distance readings. I also took into consideration the comparison algorithm. Now here are the results. I did the independent t-test for the maxillary intercanine distance gender-wise comparison and found out that males had significantly higher values than females. Similarly, I did in case of mandibular intercanine distances, but here the difference failed to reach the level of statistical significance. These are the graphs for the same. Here is the summary for the same. Then I did the paired t-test for the comparison of intercanine distance measurements among males only between the manual and the digital readings, and no statistically significant differences were found. Similarly, I did in case of females, and similar were the results here also. Then I did the descriptive statistics for the male-wise readings, and for the female vice. Now here comes the most amazing part, that is the comparison of my study nationally as well as internationally. I compared my study nationally and internationally and found out that my manual and my digital readings were much nearer to the study done by Dhara Parekh in Gujarat, as you all can see over here. My digital readings were more appropriate as they had less errors. The intercanine distances can vary due to genetic and environmental factors as well. The gold standard methods are indeed less expensive. These were my references. Thank you so much.
Thank you, Doctor. Judges, please note that was DB10. Judges can now ask questions. Christopher, sir.
Good original research you have done. Good effort you have made. So what is your conclusion of the study, what you have done?
So basically, I have concluded the Haryana region's male and female wise intercanine distance readings, so that if any of the cases comes for the bite marks, we can get to know that from which region it belongs, as I have also compared my study with the other studies. So basically, we can get to know the main culprit. We can go to the main culprit. The region can be understood with the help of the mean readings.
Okay, doctor.
Thank you, sir. Next, we have
one second. So the next next 5 presentations will be judged by Dr. Bindu. I think Dr. Bindu is there.
Yes, Bindu ma'am is there.
Yes, sir. Yes.
Yeah. Joe, now we have to spotlight Bindu ma'am when she comes for the question and answer session.
Sure, sir.
Okay.
So up next, we have DB11. Judges, please note DB11. DB11.
Sir, am I audible, sir?
Yes, you are, doctor.
Okay, sir. I will share my screen now, sir.
Go ahead, please.
So is my screen visible?
Yes, it is, doctor.
Okay, then, sir, I will start.
Yes, go ahead.
Good evening, everyone. My research paper is titled Comparative Evaluation of Mucosal Vibration with Topical Anesthetic Spray to Reduce Pain During Administration of Local Anesthesia, a randomized controlled clinical trial in young adults. People generally don't like to visit a dentist. They believe dental procedures to be painful, which they are, but local anesthesia helps to reduce pain. Local anesthesia are traditionally given using injection, and the sight of the needle makes any patient anxious and fearful. In such situations, topical anesthetics are a boon to the dental surgeon. They control pain perception, and their effects are limited to 2 to 3 mm beneath the mucosa. But their usefulness has been debated in several studies, especially during deeper nerve blocks. A newer vibrotactile device called Dental Vibe has been introduced in the market to reduce injection pain that works on the gate control theory of pain given by Melzack and Wall. Topical anesthetics act by preventing the flow of potassium and sodium ions and block the transmission of pain stimulus. Mucosal vibrations produce micro pulsations that are transmitted at a faster rate than large nerve fibers, which reach brain quickly and activate inhibitory neurons, blocking the pain stimulus. The objective of the study was to compare the efficacy of mucosal vibrations and topical anesthetic spray in reducing pain during administration of local anesthesia. Our study was a randomized controlled clinical trial with a split mouth design, and flip coin method was followed for randomization. Individuals above 40 of age requiring bilateral extraction of maxillary premolars for orthodontic treatment were selected for the study. Sample size was 15 and was calculated based on a result of a previous study done on children. Individuals in ASA class 1 category having normal healthy gingiva with no allergy to the components of local anesthesia were included in the study. Individuals who had any systemic conditions were excluded from the study. Ethical approval was obtained from the Institutional Ethics Committee, and the trial was registered with Clinical Trial Registry of India. Intervention is intraoral mucosal vibrator, a power toothbrush, Colgate Preclinical 150C, was covered with a sterile glove and used to apply mucosal vibrations. Compared agent is topical anesthetic spray. Outcome was pain experience during administration of local anesthesia, and it was measured using Von Baker's Faces Pain Scale, a self-report scale, and faces, legs, activity, cry, and consolability pain scale, a behavioral scale. The mucosal vibrator was placed in the buccal and the palatal aspect during administration of local anesthesia. The topical anesthetic spray was applied in the buccal and the palatal aspect before giving local anesthesia. The obtained data was analyzed using SPSS software version 20. Pain scores of both scales were expressed as mean and standard deviation. Comparison between groups was done using unpaired t-test. A p-value of less than 0.05 was considered statistically significant. This was the consort flow chart followed for the study. A total of 15 participants with an average age of 19.13 years completed the trial. Comparison between the study groups using Von Baker's Faces Pain Scale showed that mucosal vibrations group had lower mean pain scores as compared to topical spray group during buccal and palatal infiltration injections. Similar results were obtained using faces, legs, activity, cry, and consolability pain scales during buccal and palatal infiltration injections. Strengths of the study are: patients selected for study required bilateral extraction of maxillary premolar teeth. So the extracted teeth were not affected by any pathology and the surrounding tissues were normal. Thus, pain score obtained were reliable. As pain perception may vary markedly between patients, a split mouth design ensured that each patient acted as his own control and the pain perception is not varied. The results of this study were supported by similar studies conducted by Ludenberg et al., Amina M. al., and Sandeep Tandon et al. Respectively, which concluded mucosal vibrations to be better at reducing pain perception during local anesthesia administration. A customized power toothbrush implementing the principle of dental vibe was used to apply mucosal vibrations. Future recommendation is to conduct more research with symptomatic patients, as participants of this study were healthy and without pain. As a healthcare professional, it is the primary responsibility of a dental surgeon to provide dental care with patient comfort. From this study, it is evident that mucosal vibrations are more patient-friendly and effective than topical spray at reducing pain during administration of local anesthesia. I would like to conclude by saying that newer techniques like mucosal vibrations need to be incorporated in practice or should replace traditional methods like topical spray for being providing at patient comfort during administration of local anesthesia. These are the references for the study. Thank you.
Thank you, Doctor. Judges, please note that was DB11. Bindu ma'am.
Thank you, DB11. It was a wonderful presentation, and you have done it very systematically with the Picot criteria and all in the objective. Then I have a question for you. Why did you choose that Wong Baker's scale?
Ma'am, it was like we selected the scale as it is very easily understood by the patient. As it is a self-report scale, the main intention was the patient should be easily able to describe what type of pain it is. As it is a pictorial scale, the patient easily could understand the scale. That's why we use this scale now.
Okay. And have you done this mucosal vibration in your practice?
Ma'am, actually, I'm just passed out of my internship. I'm not actually started my practice. The thing is, actually, ma'am, dental vibe is very expensive. It's like around $500. So that's the main issue. It's costly. So maybe if more people, and it is not used much in practice also. So if people start using it in practice, maybe the cost would drop. It's actually better also. The previous studies actually say it's much better than the spray. Spray has many difficulties, like it is very bitter to taste, and in some patients it causes difficulty in swallowing.
Okay. Okay, it was a wonderful presentation. Thank you.
Thank you very much, ma'am.
Thank you, doctor. Thank you, ma'am. Moving on, we have DB12. DB12, please unmute yourself and start your screen share.
Is it visible?
Yes, it is, doctor.
Am I audible?
You're audible, doctor.
Yeah.
You can start, doctor.
A warm welcome to everyone. I hope all of them are safe in their respective places. Today, I'm here to talk on dynamic implant navigation system, a review. Restore your smile with implants designed to blend it with your natural teeth. Now moving on to the abstract. Implant placement using static guided surgery occurred due to the CBCT discrepancy and incorrect placement of guide for gross deviations in implant positions to occur. Now, the introduction. Dental implant treatment planning and placement has benefited from accelerating technological capability in office-based imaging and complex simulation and planning softwares. Dynamic navigation improve the process by providing surgeons a real-time navigation tool to improve the accuracy of implant placement. Various guidance techniques have emerged to transfer the planned digital information to clinical settings. Some of the techniques available are computer-guided static implant surgery, computer-guided dynamic implant surgery, and the robotic implant surgery. What is computer-navigated implant system? Computer-navigated implant system is empowered by a motion tracking technology which tracks the dental drill and patient position throughout the implant placement procedures by integrating a surgical instruments, three-dimensional images, and optical positioning devices. The patient and the drill must be over the line of sight of tracking camera. This is a picture of dynamic implant navigation system. These are the indications. It is used for the patients on the same day of CBCT scan and patients who have limited mouth opening and also in difficult areas such as second molars, and also when the static guides cannot be used owing to tube size and where the direct visualization is difficult, and also to placement adjacent to the natural teeth in situations in which static guide tubes interfere with ideal implant placement. How does it work? It has an active or passive tracking arrays. Active system emit light which is tracked by the stereo cameras, and the passive system using in which light is emitted from a light source is reflected back to the stereo cameras. The device attached to this allows the registration of the arch to camera with attachment arrays. The array is positioned extraorally, which contains fiducial markers. The implant handpiece with array allows triangulation. Here, the dynamic navigation system is composed of three parts: the CBCT and the SMILE plan used to set up implant treatment plan, and a position sensor tracks the handpiece and patient movement in real time. The monitor guides surgeon in position the handpiece is optimal location for accurate drilling. These are the components: handpiece attachment, patient jaw attachment, a system card which consists of a camera, computer with navigation software, natural or fiducial markers. Here, this is a fiducial clip which allows for an impression of patients to be taken, and minimum of 4 fiducials should be placed and spread out throughout the arch. Here, exploring training dental implant placement using computer-guided implant navigation system. Here, a clip with fiducials that are placed in the patient's mouth before the CBCT scan. This is a workstation graphical user interface and a stereoscopic camera. Now, principles. We have 3 principles: registration, where the mapping the extraoral clip to the CT image; calibration, mapping the drill tip to the body of the handpiece; and tracking, where the mapping the body of the handpiece to the extraoral chip. This is an image. Here, a contra-angled handpiece along with the handpiece tracker is assembled and calibrated. Here, after calibration of handpiece, there is a contra-angle handpiece check calibration. Workflow. Before surgery, we have a CBCT with clip with fiducial markers and a virtual planning of ideal 3D implant position. This is a dynamic navigation system software which allows the design of implant. And after the surgery, we will be having an attachment of array to the clip with fiducial markers and registering the clip with array of handpiece with similar array to the navigation system. And next, we'll be ensuring the direct line of arrays into the overhead cameras. And last, implant placement to the real-time navigation. Here, an implant drilling occurs where depth indicator changes the color from green to yellow when the drill is 0.5 from the target depth, and yellow turns red when it indicates the stop of the depth of osteotomy. Here, there is a surgical assistant in charge of suctioning. Advantages. In single appointment, we can do reduced harm to the patient and it is increased safety, simpler and faster planning, low pre-procedure cost, and improved ergonomics. Disadvantages are
Thank you, doctor. The system has automatically cut it down when it was 6 minutes. Judges, please note that was DB12. Bindu ma'am, you may ask questions.
Thank you, DB12. What kind of a study was that? Is it a
DB12?
Ma'am, am I audible?
Yes, yes.
It was not a study. I just referred some of the articles.
If we can do a study, that will be better. But it's a great thing that you have presented during this COVID time. Okay, it was a good presentation actually. But you try to do some original research. Okay.
Okay, ma'am. Okay, ma'am. Thank you.
Thank you, doctor. Thank you, ma'am. Up next, we have DB13. DB13, could you please unmute yourself and start the video?
Yes.
Yes. You can also start the screen sharing. You can start, doctor. DB13, please unmute yourself.
Okay. Is it now visible and audible, sir?
Yes, now it is, doctor. You can start.
All right. All right. Thank you, sir. A warm good evening to all the jury members and my dear friends. My name is DB13, and today for this paper presentation, my topic is nano dentistry, the changing face of dentistry. These are the topics which we will be covering in this presentation. And now let's have a brief introduction of nanotechnology. The word nano is derived from Greek word that means dwarf. Basically, 1 nanometer is equal to 10 raised to power minus 9 of a meter. According to National Nanotechnology Initiative by Government of India, nanotechnology is science, engineering, and technology conducted at nanoscale, which is about 1 to 100 nanometers. Now the definition of nanodentistry, it is the application of nanotechnology to diagnose, treat, and prevent dental diseases in the range of 1 to 100 nanometers. Now, let me have a little bit history of nanodentistry. The concept of nanotechnology was set up by physicist Dr. Richard Feynman in 1959. And then R.A. Fritter in year 2000 coined the term nanodentistry. Basically, it took around 40 years to invent nanodentistry from the nanotechnology. Now, the application of nanodentistry, on the basis of their uses, on the basis of their technology, there are two main approaches of nanotechnology in dentistry. First is top-down approach and second is bottom-up approach. In top-down approach, we use the bulk material and we break down the bulk material into fragments, and fragments are further broken down into nanoparticles, and that's how we form nanoparticles. Just opposite of it, we use bottom-up approach. In bottom-up approach, we use the particles whose size is lesser as compared to nano-range particles. That means atoms or molecules. We fuse the atoms and molecules and form clusters. And clusters, some clusters, after summing up, they form nano-range particles. Here are some examples of top-down approach: nanocomposites, nano-impression materials, nano-ionomers, which are basically modified GICs, implants, nano-adhesions or solutions. In all these materials, we use one, you can say, filler particle that should be in nano range. Now the examples of bottom-up approach: nano-anesthetics, tooth regeneration, nano-diagnosis, nanotherapy, and dental durability and cosmetics. In all these, we use the bottom-up approach. Now the nano-robotic dentifrices, which are also called as denti-robots. These are basically delivered by either by mouthwashes or toothpaste. How do they exactly work? They cover the whole surfaces in the oral cavity, like whether that is subgingival or supragingival. They cover all surfaces in the oral cavity. And how do they work? They convert organic material into harmless and odorless vapors. That's why we can use these nanorobots in the patient which are having their chief complaint as halitosis uh, or cavity. Now the nanometers, nanotweezers, and nano encapsulations, nano suture needles and nano needles. These both are delivered. These both are used for delivering local anesthetics for surface anesthesia. In above picture, you can see right here, the nano needles are used in injecting the local anesthesia. The tip of these nano needles is not touching the nerve endings. This is the pro tip. This is the main tip, that these do not, by using this, we do not feel the pain. And the nanotips are used for scaling. This was a report which actually I have, I searched a lot of things related to dentistry and 2 days time. So this was the report at 10th November 2020, top 10 emerging technologies of 2020. One of them was microneedles for painless injection and tests are being used nowadays. That was the main motivation for me to make this presentation, because if microneedles are trending in 2020, nanoneedles can be trending in near future. So that's why these are more in trending. And nanoneedles are also fabulous in cosmetic dentistry, like in pigmentation, detanning, and all. Now the application of nanorobots in cancer treatment. These nanorobots contain capsules which further contain the drugs that will be used to kill the tumor cells. So these will recognize the tumor cells by biosensors, and we will eject them, and they will go at the tumor cells, and they will work. Now, here is also given: the scientists have genetically modified Salmonella bacteria that are drawn to tumors by chemical secretion by cancer cells. Now, we all know nanodentistry is costly, but these are the reasons due to which we want the nanodentistry to be in our profession, because of their better aesthetics, fast and accurate diagnosis of oral diseases with small diagnostic machinery, superior hardness, strength, translucency, and superior durability of nanodental materials, and excellent handling properties of all nanodental products.
Thank you, Doctor. You have actually been muted by the system because the 6 minutes are up. Judges, please note that was DB13. Ma'am.
DB13, thank you. It was an innovative topic, and you have taken a great effort for the background work. And I haven't seen the references actually, but it was a nice presentation. Thank you.
Thank you, ma'am. Up next, we have DB14. DB14, you can unmute yourself now.
So am I audible?
Yes, you are, doctor.
Hello. So am I audible?
You are, doctor. You are audible. You can start your screen share now.
Yes, I'm sharing the screen.
You can start.
Hello everyone, I am DB14. The topic of my paper is temporomandibular disorders, the clicking jaw. The contents which we will be covering here, these are the introduction, objective, the chief complaint of the patient, the classification of temporomandibular disorders, and the treatment. So the objective is to determine diagnosis, treatment, and prophylactic measures which are used in temporomandibular disorders. Now, what is the temporomandibular joint? A temporomandibular joint or TMJ is the area where the mandible articulates with the skull. It's a complex, multi-axial, synovial bicondylar joint, and the temporomandibular disorder is the disorder of TMJ. It may involve the joint and as well as the muscles as well. The importance here we have is that more than 10 million cases per year have been reported in India of temporomandibular disorders. The patient consult a dentist because of pain and compromised movement of the jaw joint and the surrounding muscles. Now, the chief complaint of the patient is there is pain in the forehead, there is pain in the eyes, the mouth is having discomfort in opening because all the muscles are strained, the teeth are clenching and grinding at night. This is also one of the main problems which are countered by the dentist. There is a difficulty in swallowing in the throat, and there are jaw problems as well. So when we come to the functional anatomy of temporomandibular joint, basically it is articular disc, articular surfaces, and ligament and joint capsules. And the diseases which will be related to all these only. And if anyone is compromised, there will be a pain in that region. So when it comes to the nerve supply and blood supply, in one of the presentations earlier, Dr. Brahim has also mentioned that it is really very necessary to know the nerve supply and blood supply of the temporomandibular joint. So the mandibular branch of trigeminal nerve supply the joint as well as the muscles of mastication, and the arterial blood supply is provided by branches of external carotid artery, predominantly the superficial temporal branch. Now the nerve supply is really very important because the associated muscles of mastication are they are innervated by the nerves of their name only, and it is important to know the nerve supply because deferred pain is also a concept in which is very frequently counted in the clinics. So when we look at the movements of the temporomandibular joint, the protection of mandible is carried by the lateral and medial pterygoid muscle. The retraction is by the temporalis and mesenteric muscle. The elevation is by the medial pterygoid, temporalis, and mesenteric muscle, and the depression is by lateral pterygoid muscle. Now, when it comes to the classification of temporomandibular disorder, which was given by Jeffrey Okeson, it could be classified as the myofascial pain and dysfunction, which have myositis, fibromyalgia, neuropathic pain, and chronic pain syndromes. Next, we have the TMJ functional dearrangements. It could be a disc displacement, that is an internal dearrangement, dislocation, that is hypermobility disorders or luxation, hypermobility disorders like ankylosis and post-traumatic disorders. Now, the TMJ degenerative or inflammatory joint diseases are osteoarthritis and rheumatoid arthritis. When it comes to the treatment of temporomandibular disorders, the conventional approach is the wrist pivot technique. In it, the dentist put their thumb over the mandibular third molar and put downward and backward pressure on the molars. Now, the refractory atraumatic temporomandibular joint dislocation is corrected by the wrist pivot technique. The surgical approach that we have is that while surgery is not considered as often for the treatment of this disorder, there are instances where surgery is definitive and sometimes the only treatment option, such as the TMJ ankylosis. 5 to 10% of all patients undergoing treatment for temporomandibular disorders, they require surgical intervention. There is a spectrum of surgical procedures currently used for the treatment of temporomandibular disorders, ranging from TMJ arthrocentesis and arthroscopy to the more complex open joint surgical procedures referred to as arthrotomy. Now here we can see the pre-operative and post-operative photographs of the patient. The midline has been corrected here. Now we can see that there is a shift of the mandible, and as well as the midline is also not proper. And as we can see in post-operative, it has been corrected. Now, when it comes to the pharmacological management, now the analgesic effect of the NSAIDs, non-steroidal anti-inflammatory drugs, it is specific in case of temporomandibular disorders where pain is the result of an inflammatory process. Wherever there is an inflammation, then only NSAIDs will work. In myofascial pain, primarily involving the muscles of mastication, they can be relaxed. In the presence of high level of emotional stress associated with temporomandibular disorders, tranquilizing agents such as benzodiazepines are used to help the patient cope with the stress by helping reduce the perception or reaction to stress. For patients with poor sleep patterns, muscle relaxants are particularly helpful in alleviating insomnia, in addition to their muscle relaxing effects. Now, when it comes to the occlusal splint therapy, it is the most common form of treatment provided by dentists for temporomandibular disorders. It is having a cushion effect. The splint have a cushion effect. The idea is to protect the teeth from abnormal high loads in clenching and grinding, and also to reduce the maximum loads on the temporomandibular joint. By distracting the occlusion, maximum contraction of the masticatory muscle is also prevented, which reduces the muscle pain. So I would like to conclude that about 20 to 30% of population is affected to some degree by the temporomandibular disorders. It is the second most frequent cause of orofacial pain after toothache. And by proper assessment and intervention, we can enhance the lifestyle of the patient. These were my references. And thank you. Thanks a lot.
Thank you, Doctor. Judges, please note that was DB14. Judges can now ask questions. Bindu ma'am, please.
Thank you, DB14. Have you referred any articles regarding this? Regarding your topic, have you referred any articles from the journals?
My voice is not audible.
Am I audible now?
Hello.
Yes, ma'am. Yes, you are, ma'am.
You are audible. I think Dr. DB14, check your audio. Ma'am is very audible.
Hello.
Yes, go ahead. We can hear
Hello?
you. DB14,
I
we
think
can hear you.
he's having some connectivity issues.
Yeah, net connectivity, ma'am.
Is it okay?
I guess your voice is not audible. It is.
Hello? How is it now? DB40?
I think he got stuck, madam. I think net issue is there.
Yeah, I think. Okay, thank you, DB14, for your presentation.
Your voice is breaking. It's not audible.
Fine, fine.
Okay,
you can go to the next one.
I think we'll carry.
Yes, sir. Up next, we have DB15.
Yes, now it's okay. Now it's okay.
Yeah.
Hello? Is it
Yes,
audible
now
now?
your voice is fine.
Okay. I asked you, have you referred any articles? I think again the net problem is there.
Yes, I think Joe, you can go ahead with the next presentation.
Yes, sir. Judges, please note, this is DB15. DB15, please unmute yourself and start the screen share.
Yes, sir. Can I audible, sir?
Yes, doctor, you're audible, doctor.
Thank you, sir.
Yes. You can start now, doctor.
Good evening, ma'am and sir. Today's my topic is drugs used in dentistry. Let's start. Drugs are various types, but the non-steroidal anti-inflammatory is the most common drugs in dentistry. The drugs are aspirin, diclofenac, ibuprofen, ketoprofen, ketorolac, nemisulide, pyroxicam. Most favorite is diclofenac and ibuprofen. Doses are 15 mg TD, then oral, and 75 mg deep intramuscular, and ibuprofen 400 to 600 mg TD. Which time we are given these drugs? Indications are toothache, post-operative inflammatory condition, pain, wound edema, etc. Contraindications are always hypersensitivity. And precautions, which cases we cannot give these drugs, asthma and urticaria. Ibuprofen is also same. But
excuse me, Dr. DB15, can you please make it a big screen and change the slides, please? Sorry for that.
Yes, yes, sir. Please repeat.
Can you project in the full screen and change the screen?
Sir,
slides are not changing.
Sir, it's full screen, sir.
No, you haven't gone to play mode.
1 minute.
Put the play mode next to that percentage. There is something called play mode. Wine cup kind of thing. Just click onto that.
There's a wine glass right there, down there.
1 minute, sir.
Yeah, next to that. Next to that.
That's sir.
No, no, go on to the left side. You know, according to the right side, you go. There is a wine glass kind of thing, wine kind of thing. That is a
Wine.
full. Yeah, yeah. Put that.
Okay, okay. Now it's right, sir.
No, no, it has not come again. You have to click onto that. You didn't click onto that. Just click onto that wine.
Dr. DB15, are you actually seeing the full screen on your computer, doctor?
Yes, yes, sir.
Okay, what you need to do is you need to stop the share, then click share screen, and this time choose window instead of choosing a particular window, doctor. Please do that.
Joe?
Yes, sir.
You want to go to DB16 and then come back to DB15? Let's not waste time.
Sure, sir. Yes.
And you take care of DB15 personally.
Sure, sir. I'll do that. Up next, we have DB16. DB16, you can please unmute yourself and you can start the screen share, doctor.
I think Dr. Sri will be judging this, no?
Yes, ma'am.
The problem that judges, doctor.
Dr. Sri is there?
Sri Lakshmi, ma'am, you are there?
Yes, sir. Ma'am is here, sir.
Can you unmute her? Can you make ma'am spotlight, ma'am? And
yeah, ma'am was here a minute ago, but maybe an internet issue. Sri Lakshmi, ma'am.
Joe, Dr. Joby?
Yeah.
Before we start DB16, just want to announce that one of our judges of dental art, Arab orthodontist from Bahrain, Dr. Shahala Abdul Gaddafi, has come in online to see these presentations. Ma'am, extremely happy to see you here. Ma'am, can you switch on your video?
You can unmute ma'am and ma'am can have a talk. Thank you so much.
Ma'am, can you unmute and switch on your video? Yes, ma'am. Dr. Shahala here, orthodontist based in Bahrain, training an artist herself. She has took all the pains of going through 170 odd artistic works of our dentists. Ma'am, thank you so much for doing that. We really appreciate your efforts and thank you so much for coming online. Go ahead.
Thank you so much. Thank you for trusting my judgment, and all of you guys have done wonderful. I really, really enjoyed the art. I enjoyed going through it. The technique was amazing. I wish you all the best. I'm just here to see all the amazing work, and I'm sure I will learn from you guys. Thank you so much. Thanks, Dr. Bino, for introducing me. Thanks for the very kind introduction, and thanks for trusting.
Thank you.
I have to unmute now. Take care.
Thank you very much for coming in and encouraging all these presenters here. They're all undergraduate presentations going on, but they are doing good
Amazing
job, better than graduate, postgraduate presentations. We are seeing excellent presentations here. Thank you so much, Dr. Shahala. We appreciate it. Take care.
Thank you so much. Thank you. Bye-bye.
Joe, go ahead with DB16.
Shall I start?
Yeah.
Yes, you can start, Doctor. DB16, you can start.
Good evening, everyone. I am Sakshi Sharma, DB16, and I'm here to speak on the topic oral health and diet. Major topics: introduction, sugar substitutes and sugar-free products, effects of malnutrition on oral structures and its development, diet and the development of the oral cavity, infant oral health knowledge and awareness, management of perinatal and infant oral health. Coming to introduction, a balanced diet is important for overall health as well as the oral health. The nutrition we get from a balanced diet helps in the renewal of tissues and in fighting with infections. Poor diet can result in tooth decay and gum diseases. Food high in sugars can increase the acid production, which erodes the tooth's outer layer enamel and results in decay. Coming to choosing the right meals, drink plenty of water, eat a variety of foods from each of the 5 major food groups, including whole grains, fruits, vegetables, lean sources of proteins, low fat and fat free dairy foods, sugar substitutes, and sugar free products. Sugar substitutes are available that look and taste like sugar. However, they are not digested the same way as sugar, so they don't feed the bacteria in the mouth and therefore don't produce decay causing acids. They include sorbitol and mannitol. Other sugar substitutes that are available in the US include saccharin, advantame. Coming to chewing gums, chewing sugarless gums is actually beneficial for your teeth as it helps in dislodging the food that becomes stuck to your teeth and increases the salivary flow to buffer the mouth acids. Some gums contain ingredients that can reduce cavities as well as heal the areas on the teeth where cavities are beginning. Chewing gums can be a problem, however, if you have a jaw pain or other issues with your jaw. Effects of malnutrition on oral structures and its development, oral manifestations of protein deficiency, formation, eruption, and alignment adversely affects periodontium cells, that is fibroblast, osteoblast, cementoblast, caries-prone teeth, retarded cementum deposition, degenerative changes in the gingiva and periodontal ligament, poor calcification of dentine and matrix, reddening of the tongue with the loss of papilla. Oral manifestations of vitamin deficiency, vitamin A, decreased epithelial tissue development, vitamin D, lowered plasma calcium level, vitamin C, dental pulpal alterations and bleeding gums, vitamin B1, cracked lips, vitamin B2, vitamin B3, angular cheilosis, vitamin B6, periodontal disease, vitamin B12, angular cheilosis, iron, salivary gland dysfunction. In the A1, we can see hypoplasia and pits on the surface of the enamel, which are correlated to lack of vitamin A. And on the right side, we can see the hypoplasia on the surface of the enamel correlated to the lack of vitamin D. Now, my friend will further continue this presentation.
Am I audible, sir?
A little bit louder,
Yes,
doctor.
you're audible. I am DB16 and I'm continuing the topic oral health and diet. Diet and the development of the oral cavity. Diet influences the development of the oral cavity depending on whether there is an early or late nutritional imbalance. An early nutritional imbalance influences may cause malformations. A shortage of vitamins and minerals in the face during conception influences the development of the future embryo, influencing dental organogenesis, the growth of the maxilla, and skull or facial development. What are the conditions that may develop due to nutritional imbalance? Deficiency of protein can lead to atrophy of lingual papillae, altered development of the maxilla, malocclusion, linear hypoplasia of the enamel. Deficiency of lipids can lead to parotid swelling that can cause hyposalivation, altered mucosal trophism. Deficiency of carbohydrates can lead to caries, periodontal disease. These are some pictures that depicts malocclusion, enamel hypoplasia, caries. Infant oral health knowledge and awareness. Infant oral health is the foundation upon which preventive education and dental care must be built to enhance the opportunity for lifetime free of preventable oral diseases. A young child's dental environment is very complex because they are dependent on their mothers or caregiver. So hence, parents play an important role for maintaining the oral health care of their children. For example, inappropriate bottle use patterns such as addition of the sweeteners to the liquid and prolonging exposure of sugary liquids at the bedtime can cause early childhood caries. Management of the perinatal and infant oral health. Oral health care for pregnant and lactating women. Diet of the pregnant and lactating women must be adequate, and we should also include information regarding the caries process and the food cravings that may increase the mother's caries risk. The mother must maintain the proper oral hygiene for which she can use fluoridated toothpaste, chewing sugar-free gum, etc. continued breastfeeding along with complementary foods for a period of 1 year or longer, the transfer of the drugs and the therapeutics into breast milk should be considered. For example, tetracycline cannot be given in a pregnant female because it can cause yellow discoloration in teeth in the child. Oral health care of infant, dietary habits. A good diet for a child's growth and development is very important, for which we have to introduce child to a variety of foods from the 5 major food groups that we discussed earlier. Counseling regarding non-nutritive habits such as digit or pacify sucking, bruxism, abnormal tongue thrust. These habits can cause malformations. Routine dental assessment. Assessing the infant's risk of developing caries and determining a prevention plan is very important. So here I conclude this topic with the conclusion that the knowledge of the impacts of diet on the oral health care is very important. So we can prevent the disorders of the oral cavity due to deficiency of the nutrients. These are the references. Thank you.
Thank you.
Thank you, doctors. Judges, please note that was DB16. Judges can now ask.
Sir, am I audible, sir? Am I audible?
Yes, yes, ma'am, you are, ma'am.
Yes. DB16, your presentation was excellent, and the topic of selection was also good. So to just start with, as a dentist, how do you think you can reach the public in common to increase awareness about oral health and diet?
Ma'am, we can increase the use of posters and educate them, and we can, whenever there is a camp, you can give them knowledge about how oral health is important. Many a times like they feel that it is assumed that it is already known to everyone, but people take it for granted, because it's topic like it's known to everyone, but it's not like that. We need to promote information, and we should spread the awareness about the oral health and diet.
Yes. So a planned program which is targeting a specific audience would be much more effective rather than continuing a program for community as a whole. Specific populations would be a still better plan of action. Nice presentation, and all the best for your further presentations as well.
Thank you, ma'am.
Thank you, ma'am. Judges, please note, up next we have DB17. DB17 can now start sharing.
Am I audible, sir?
Yes, you are, doctor.
Yes.
You can start the screen share, doctor, now.
Yes, sir. It is rightly said by Hippocrates that nature is the best physician. So good evening to one and all present here. Today I'll be presenting the research paper on the topic, Assessment of Antimicrobial Potential of 30% Ethanolic Papaya Leaf Extract against Candida albicans and Enterococcus fecalis, which is an in vitro study. So, to begin with, antimicrobial resistance is a worldwide threat right now. The antimicrobial resistance that is developed by pathogenic bacteria is going to cause a drastic problem in the future generation, because by the time we start, like in 20 years from now, when we see it, the patients will be so resistant to the antibiotics that we prescribe the patients that it will be difficult to control a very mild infection. So you must be thinking, if it is so risky, why don't we have an alternative to that? Yes, there is an alternative, and in dentistry that is called as green dentistry. Green dentistry is an natural way where we go back to our nature and we minimize waste, we conserve energy, it also reduces time. Green dentistry as an advent is the traditional way, and it has always been of our use. So Ayurvedic medicine, for example, dates back to 1,000 years, and it was frankly in India that we started using all these herbs and medicines, right? So the papaya leaf or Carica papaya leaf is known to have anti-amoebic, antifungal, antimicrobial, anti-ulcerogenic, diuretic effect, and along with anti-fertility, and also it has scavenging activity. So that is why I chose Carica papaya leaf extract in general. So the aim of the study was to assess antimicrobial potential of 30% ethanolic papaya leaf extract against two organisms in specific, Candida albicans, which is a fungus, and Enterococcus faecalis. So the materials used in the study are listed below. Now I'll move ahead to the method that we use to carry out this study. It is an in vitro study as mentioned earlier. So first, collection of papaya leaves in and around Bangalore, as we needed a lot of leaves. So we collected around 30 to 40 leaves for this procedure. And then the papaya leaves were dried in hot air oven at 40 degrees Celsius. The processing was done in Socrates apparatus with 70% ethanol. Next, distillation was carried out for 2 hours. And in the end, again, the extract was dried and powdered. And the final sample was obtained by dissolving it in DMSO or dimethyl sulfoxide. Now, the culture media used was Luria bertini agar media for Enterococcus faecalis and potato dextrose agar media for Candida albicans. The controls used, these were the culture media used, and the controls used was 0.2% chlorhexidine and fluoroconazole. So these, as you can see on the screen, are the culture plates, and you can see the zone of inhibition in Candida albicans and E. faecalis in both the culture plates. This is the minimum inhibitory concentration showed by both the bacteria and the fungus, Candida albicans and E. faecalis. So this study showed excellent results because a zone of 15 mm of inhibition was seen with Enterococcus faecalis, and 13 mm of inhibition was seen with Candida albicans. While the control, there was only 10 mm and 11 mm of inhibition. So in this chart where you can see that the bacteria becomes resistant until 2.5% of the solution is used, that is the minimum that we use, but 30%, 20%, 10%, 5% has been known to be effective for C. albicans. On the other hand, it is known to be effective till 2.5% for E. faecalis. These are the minimum inhibitory concentrations. Now, the medicinal properties that these plants have are because of the phytochemical constituents, basically flavonoids, alkaloids, and saponins. These have various roles in having the antimicrobial and antifungal potential. So we have compared this with previous studies, and this was the study of this study was first of its kind, where 30% ethanolic papaya extract was used, and present study and other studies are given in comparison in this table. So now I would like to conclude that we could see from the results that an amazing level of inhibitory zone was achieved, and both the papaya media, papaya extract as a media is really helpful with both these infections from both of these organisms. So and it is very important that rather than moving to chemicals and drugs, why not we go back to our ancient ways of adapting from medicinal plants, which is going to help us more in the future, because these drugs are someday going to get resistant and patients are going to fall sick, and a simple fever can literally be the reason for death. These are my references. I would like to thank my guides, Dr. Anjan Ji and Dr. Padma Bhatt. Now I'm open to any questions.
Thank you, Doctor. Judges, please note that was DB17. Sri Lakshmi ma'am, you can now ask questions, ma'am.
Yes, DB17, thank you very much for your presentation.
Yes, ma'am.
Can you please explain me as to why you have specifically used only 30% of the ethanolic extract, and why not beyond that and lesser than that?
Ma'am, we use 10%, 20%, 30%, all of these. So we wanted to see that with these concentrations, how it is. I have used all the three in my study, but I've just presented about 30% because it was the highest level that we achieved. We didn't go beyond that because we could only investigate with 3 samples, because it was obviously, if we keep on investigating, we can go to a higher percentage, but we thought that 30% we can use as a basic amount, right? If we increase the amount, then obviously the cost will also increase, because
so may I know on what basis it was selected? May I know on what basis that particular 30% was selected?
Ma'am, in general, like I have done the study with 10%, 20%, 30% itself. But since 30% is the highest concentration and it showed the maximum zone of inhibition, that is why I use 30%.
Okay.
With 10% and
Fine.
20%, the zone of inhibition was a little less compared to 30%.
Yes. Okay. And why is that only two specific species of Candida has been taken and other species have been ruled out? Like, have you not done it in a comprehensive way to so that the comparisons will be still better?
Ma'am, so we had to grow the organisms on the culture plate. So we had taken just one species both. So like we, as I said, it's a first of its kind, and more research has to be done on this and to even check the economic feasibility and in the clinical setting how effective it is. So we just started with two organisms and such to just bring out our topic and to get attention on that, and maybe we can go ahead to other organisms as well.
Okay. By any chance, can you find out any few factors that could have, possibly affected the outcome of your research findings?
Ma'am,
anything which you feel like.
Ma'am, according to me, it's because of the phytochemical constituents of the extract, the flavonoids, alkaloids, and the saponins. So these have, when we grew it on the media, as soon as we grew, as soon as we put the sample on the media, within, I think, a few hours, we could see a little bit of inhibitory zone started to form. So that is because the colonies were, the colony that was forming by these organisms was immediately stopped because of the sample, because it had such a strong effect on it. So according to me, it's because of the properties that the leaf has in fact. So there have been studies on papayas fruit also, seeds also, stem also, but when I carried it out on the leaf, I found it to be the most effective.
Okay, your entire project was very unique, in fact. So getting back to green dentistry is a very good thought.
Thank you, ma'am.
All the very best.
Thank you so much, ma'am.
Thank you, doctor. Thank you, ma'am. Moving on, we have DB18. DB18, you can unmute yourself and start your screen share.
Can I start, sir?
Yes, you can, doctor. All the best.
Hello, everyone. I'm DB18, presenting a review article on should psychoodontology be included for undergraduates or not. Quoting a famous quote, I have learned that people will forget what you said, people will forget what you did, but they will never forget how you made them feel. So always said, make them feel better and better. Abstract to my article, the term psychoodontology indicates the principles of psychology in dentistry. As we know that patient-clinician relationship is very important for healthy and better practice. So the above article throws a major light on goals of psychoodontology and whether an undergraduate should learn clinical psychology as in a separate subject or not specifically. Introducing my article, psychoodontology is referred as the study and applications of principles of clinical psychology to dentistry. As we know that there are different fields of psychology like environmental psychology, forensic psychology, sports psychology. So why not include psychoodontology, which deals with psychology of patients that dentists face in every day. I would look upon goals of psychoodontology. For the ease of understanding, I have divided it into three goals. First is for establishing healthy patient-dentist relationship. Next one is for reducing negative impacts or X, that is encouraging patients for avoidance or reduction of negative impacts. And third one is encouraging patients for positive things, that is for good and useful X. So coming to establishing healthy patient-dentist relationship, I would look upon a concept of empathy first. What is empathy? Empathy is listening through patients' ears, seeing through their eyes, and feeling through their feelings. So nowadays, in present era, many dentists make a mistake showing patients empathy. So always remember, patient never wants sympathy from you. Patient wants empathy. Second one is expression speaks louder than words. So as we know that non-verbal cues like your body movement, your attractiveness, your body language, they are very important compared to verbal ones. So as quoted, always remember patient is watching you no matter what. The second goal of studying psychoodontology is encouraging patients for reducing negative impacts and X. So I would like to mention here that many patients might have dental fear, that is odontophobia of instruments, extractions, and many other things. And they might also have psychogenic dental pain. So due to these reasons, they might be delayed in visiting to dental clinics, and that might create more and more dental problems. And the cycle will go on and on. So for that, psychological aspects like behavioral therapy, like counseling them for stress management techniques, that's very important. Next is psychology for deleterious oral habits. So as we know that in treating oral habits, orthodontic appliances play an important role. So according to me, apart from these appliances, counseling them counseling them for removing removal of the habits play an important role. Next is psychology for smoking and tobacco cessation. So for that, counseling patients for smoking and tobacco cessation. So for that, first dentist should understand the psychology of this kind of patient. Then and then only the dentist will able to reach the patient and will able to create a better contact. Next is avoidance of dental myths. So we all might have faced many patients which are having dental myths in our day-to-day clinics. So for that, counseling and creating a bond of trust is very important between patient and dentist. For that, first dentists need to understand what is the psychology of patient. Then and then only they can be able to explain that what's true and what's not. Next one is encouraging patients for positive and helpful acts. And in this, the most important one is oral hygiene management. Studies have shown that when psychological therapies have been included, apart from oral hygiene management in guiding oral hygiene, uh, low plaque scores and reduced gingival bleeding have been reported. So psychology plays a very important role. Encouraging parents for regular follow-ups of child. So childs, as quoted, childs are future of our country. So encouraging parents for regular follow-ups of child in dental clinics is very important. Psychological care for specialized patients, for physically challenged and mentally challenged people, not just medications, but their behavioral programs and therapies are very important when they visit our dental clinic. Here I would like to mention that nowadays concept of holistic approach is very famous. So according to me, holistic approach without psychotherapy is not a complete one. Holistic approach should include psychotherapy, which will create a true holistic approach. So many years back on Twitter, hashtag psychodentistry was very famous. So I would take a note upon that even. Concluding my article, from undergraduate level, we face patients of similar kind. So according to me, right from the undergraduate level, we need students to teach psychoodontology, so that they might face less difficulty to tackle the patient, and that will help in their overall growth, not only just in their professional life but also in their personal life. So these are my references. And ending my presentation with a motivational quote: believe you can and you are halfway there. Thank you. Thank you for patient listening.
Thank you, Doctor. Judges, please note that was DB18. Judges can now ask questions. Srilakshmi ma'am.
Yes, DB18, thanks a lot for your presentation. May I know the reason as to what has made you choose this particular topic, which is very helpful for clinical practice?
Sir, ma'am, while going to clinics, I haven't been like so much. I haven't been in so much exposure, but still, up to what I have seen, talking about me myself, I have been facing difficulty about understanding, like if we are even good at skills like practicing, and but still we are having difficulty for understanding patients, for making patient convenient that about like what plan should we go for treatment. So that made me choose this topic.
Okay. And may I know what particular factor contributes a lot to the management of the patient?
Sorry, ma'am, I can't hear you.
May I know what do you feel is the important contributing factor for the cope up of the entire psychology of a person?
It's first of all, we have to understand the patient, we have to understand how the psychology of patient works. Then we will be able to understand the patient better, and will be able to make healthy patient clinician relationship.
So communication is probably the first and foremost factor that needs to be improved from dentist point of view, right?
Yes, ma'am.
Yes. Thank you so much, and it was a very interesting topic from your end for choosing this.
Thank you.
All the very best.
Thank you.
Thank you, ma'am. Thank you, doctor. Up next, we have DB19. DB19, can you please unmute yourself and start your screen share?
Am I audible?
Yes, you are, doctor.
Yes.
Is the screen visible?
It is, doctor.
Yeah.
Okay. Thank you. May I start?
Yes, please.
Thank you. Hello, everybody. I'm DB19, and I'm here to explain you about the use of mesenchymal stem cells for bone regeneration, which is an overview. Bone is a hard connective tissue which comprises of numerous skeletal elements, and according to the stage of development and microstructure, it can be classified as primary, secondary, cancellous, and compact bone. These are the various microstructures that constitute the alveolar bone. Now, the bone formation takes place mainly through endochondral and intramembranous ossification. And in case of alveolar bone formation, it is the intramembranous development that has a chief role. It occurs when the mesenchymal stem cells differentiates into osteoprogenitor cells, which is orchestrated by a myriad of growth, differentiation, and transcription factors. This is an engineered tissue triad, which is formed with the help of stem cells, the scaffold, and the growth factors. Stem cells. The stem cells can be obtained from the embryonic tissue, fetal tissue, postnatal tissue, and certain somatic stem cells that can be reprogrammed into differentiated somatic cells. The potential MSCs that can be taken from the bone marrow-derived stem cells, the dental-derived stem cells, which can be taken via dental pulp, periodontal ligament, the exfoliated deciduous tooth, stem cells from the apical papilla, dental follicle cells, gingival mesenchymal cells, and the adipose tissue stem cells. Now, these cells are seeded onto a scaffold. A scaffold is chosen based on its porosity, surface charge, topography, biodegradability, and surface chemistry. It is classified mainly into conventional and synthetic. This table shows the basis of classification of scaffold, which is based on its degradation, the presence or absence of cells, the type of the cells, and on the basis of origin. Culture media. Culture media is broadly classified into natural media and synthetic media, which is subclassified into the classes you can see on the screen. Now, there are four main signals that are regulatory for these mesenchymal stem cells, or the MSCs, which are fibroblast growth factors, the bone morphogenic protein, beta-catenin signaling, and Notch signaling. This picture shows the action of the BMP and WNT channels on osteoblast and adipocyte maturation activity. Once the MSCs have been seeded onto a scaffold, a series of assays estimate the quality and the quantity of the MSCs, and that is via the flow cytometry analysis, immunofluorescence, the MTS assay, scanning electron microscope, osteogenic gene expression, ALP and calcium phospholipid content analysis, gene stability assay. Apart from the tissue engineering triad, for a successful bone augmentation, immunomodulation and angiogenesis is important. Immunomodulation of the MSC can be done by two major mechanisms. One is cell-to-cell, and which is direct contact, and the indirect interference by secretion of certain soluble factors. In the indirect modulation, the MSCs inhibit the proliferation of the T cells with the help of TGF-beta1 factor and the hepatocyte growth factor, which helps in the G1, G0 phase arrest of the T cells, which downregulates cyclin D2 expression and increases tryptophan degradation and kynurenine synthesis. Once there is increase in the kynurenine synthesis, these MSCs help in the secretion of something called as the IDO, which is the indolamine dioxygenase, which induces the formation of hydroxyanthranilic acid, which causes the apoptosis of the T cell via the NF-kB pathway inhibition. Also, they secrete certain barriers so as to avoid the action of the T cells in the antigen-presenting cells. Now, the MSCs affect the immunotolerance by inducing certain TREGs in systemic transplantation, and it is questionable in case of local transplantation. the microenvironment acts as a soil for these seeded cells. In case of a diseased microenvironment, the endogenous stem cells have declined regeneration ability, and the procured exogenous stem cells show impaired therapeutic efficacy. This can be overcome by the improvement and restoration of the microenvironment, which helps us in the regeneration. Nowadays, cell-free strategies are used because of the extravesicular secretion of these stem cells. The cell-free strategy uses certain exomes for the bone regeneration. With such innovative technologies, it is now easier for bone regeneration. The main disadvantages arise due to the heterogeneity of the stem cells in its source. Time and temperature are among other factors that determine the success rate of such procedure. However, the success rate depends upon the type of material chosen and the cell type chosen. Thank you so much.
Thank you, Doctor. Judges, please note that was DB19. DB19 is now open to questions. Sri Lakshmi ma'am.
Yes, sir. DB19, thank you for your presentation.
Welcome, ma'am.
Your presentation itself shows how much hard work you have actually put in. So theoretically, you have worked a lot, even like beyond a PG student. So the way you have explained is also too good.
Thank you, ma'am.
Yeah, and I just have a very simple question for you. Like you mentioned the heterogeneity of the stem cells. As in, can you name a few? Yeah. As in, what governs that particular?
Yeah, what I meant by heterogeneity is that if we procure the stem cells from a fetal tissue, they have different lines that they can be transformed into different lines. So if we, in case of alveolar bone regeneration, which is my topic, I will intend to choose a stem cell which has a direct line, so that they may not differentiate. Even when the 4 signals are given, they may not differentiate into other categories apart from bone. So heterogeneity is meant by the, it is characterized by the potency, that is a pluripotent, multipotent, etc. So that characterizes the criteria of selection.
Okay. Once again, I would like to congratulate you for your excellent presentation.
Thank you, ma'am. Thank you.
All the very best.
Thank you, ma'am.
Thank you, ma'am. Judges, please note, we have DB20. DB20, you can now unmute yourself and start your screen share.
One second, sir. Am I visible, sir?
Yeah.
Hello, sir, am I visible?
Yes, you are, Doctor.
Yes.
Okay, so may I start?
Yes, you can, Doctor.
Okay, thank you.
Please share your screen first.
Is it seen?
Yes.
Yeah, just a second.
Not yet.
Is it okay?
Your screen hasn't come up yet.
Just a second, sir. Screen hasn't come up yet.
You can stop the sharing and try sharing it again.
Okay, sir. Gosh. Okay, now is it visible?
It's loading, Doctor. Yes, now we can see, Doctor. Yes.
Okay, so may I start?
Yes, you can, Doctor. Please go into a full screen mode.
Good evening,
Yes.
everybody. Yeah. Good evening, everybody. I'm going to discuss on the topic Botox in clinical dentistry, Sjogren's syndrome, and overview. What is Botox? It is a neurotoxin that is obtained from Clostridium botulinum, and it was discovered in 1895 by a Belgian microbiologist, and it has got 7 antigenically different serotypes A to G, among which A, B, and E are the most commonly used. The mechanism of action is that BTX or the Botox acts on the cholinergic nerve terminals of the parasympathetic nerves, which causes a local chemical blockade and causes a transient paralysis. So it has got 4 steps. That is the binding of toxin into the nerve endings, the internalization of the toxin, the translocation of the light chain of the toxin, and the blocking of the transmission of acetylcholine. Now, it is being widely used in certain aesthetic and non-aesthetic conditions such as frontoglobullar wrinkles, migraine, lip enhancement, brow contouring, facial rejuvenation, and hyperhidrosis, etc. Now, over a few years, the application of Botox has been done extensively in salivary gland disorders by the dentist, and other uses of Botox in dental field are for the treatment of stylism, chronic recurrent parotitis, parotid stylosine and fistula, Spray syndrome, etc. Now, my topic is about its impact on Sjogren syndrome. So Sjogren syndrome is an autoimmune disease which affects 0.5 to 1% of the population with a strong female predilection and is caused due to the lymphocytic infiltration that causes destruction of the salivary glands. So, however, the usage of Botox for the treatment on the syndrome is uncertain, but it is effectively treated for the complications arising due to the syndrome. One being the chronic recurrent parotitis, which is caused due to the retrograde infection of the salivary gland, causing the ductal fibrosis and stagnation of saliva. So what are the current treatment options used nowadays? Is corticosteroids, gland massages, antibiotics, analgesics, minimally invasive salinoscopic dilation, anticholinergic medications, parotidectomy, etc. But the traditional and the conventional methods have got its own disadvantages, the major one being the stenosis in the Stenson's duct, which is caused by the minimally invasive salinoscopic dilation, which causes an acute exacerbation of parotitis. However, the exorbitant charges associated with the therapy is also burdening to the patient. The use of Botox may be considered less invasive and less tedious. A recent clinical trial done by Kwon et al., they injected BTX into the parotid glands of 14 patients to evaluate its efficacy and the safe treatment of chronic recurrent parotitis. Similarly, Luke et al. Proposed a case of 65-year-old woman with Sjogren syndrome and a 10-year history of recurrent parotitis who underwent a successful treatment with Botox. The parotitis accompanying the autoimmune diseases like Sjogren's, in such cases, Botox is proved to be effective up to 90%, but there exists a deficiency regarding the knowledge of the time dose response to the BTX. Now, what are the tests? The research done by Kwon et al., they did the following follow-up test. That's a 10-point visual analog scale for pain questionnaire. Salivary flow rates were assessed before and after salivary stimulation, and the salivary SPECT CT was done before and after 3 and 6 months to assess the gland volume and uptake changes. The injection technique that was uptaken by them is the application of Emla cream at the site and the injection of the diluted Botox using the insulin syringe at a dose of 25 units, which is fractioned into 3 doses, given at the upper pole, the lower pole, and the anterior portion of the gland, and later the ice pack was applied and the patients were monitored for 60 minutes before discharge. And the conclusion of their research was that it can be a viable alternative treatment option for patients suffering from parotitis due to Sjogren syndrome. Now, the currently available neurotoxins in the market are of various types. Like I told you, A, B, and E are the common antigenic serotypes that is being used. Among them, the A antigen has got neurotoxin A has got various subdivisions. So it is being marketed by various trade names like Botox, Discot, Xeomin, Pertox, Myoblock, CBTX-A. But CBTX-A is a Chinese botulinum toxin A, and it is the only toxin that is approved in China, and it contains a bovine gelatin protein that prevents the adherence of the neurotoxin to the walls of the vial, and this causes an allergic reaction, and it is only approved in China and nowhere else globally. And these are prescribed as injections and powders, which are often diluted with preserved unpreserved saline, lidocaine, epinephrine, and to an extent the sterile water. The dilution of the toxins depend on the type of the toxins. That is, for toxin A, the neurotoxin A is for 4 subtypes: the onabotulinum toxin A, the incobotulinum toxin A, the abobotulinum toxin A, and the prabobotulinum toxin A. And it depends on the type of the brand and the package insert. They give an instruction about how many units and how much dilation it should be done. but by keeping the dilution less and causing lesser diffusion to the unwanted area, by keeping the dilution less, it causes lesser diffusion into the unwanted area, hence keeping the affected area small and the duration of effect more. So the conclusion is that this is one area that has been explored very less. In future, however, prospective studies should be done in larger sample sizes, and it is required to determine the merits and demerits, as well as know a clear know-how of the duration and timing of this test. Thank you.
Thank you, Doctor. Judges, please note that was DB20. Judges can now ask questions. Sri Lakshmi ma'am. Sri Lakshmi ma'am.
Yes, DB20, thank you for your presentation.
Thank you, ma'am.
Yes, yeah. So by any chance, have you inquired about the cost of this particular drug?
Yeah, as far as I know, in India, it costs the same as that of implant. I think for a while it costs around 15,000 or 20,000, according to my
15,000.
knowledge, 15 to 20,000,
Okay.
and it's very expensive, similar to
Okay.
implant.
Okay, fine. And like, what do you think will be the other alternative drugs that could be affordable for a common person with Sjogren syndrome?
For Sjogren syndrome, normally depending on the severity and the pain, analgesics are used nowadays in India because of the cost and the treatment affordability by the patient. I think the treatment is lined accordingly. So the analgesics, the treatment options depend on the expense according to the patient in India. That's what I feel.
Okay. Okay, fine. And may I know the reason for choosing this particular drug and this particular syndrome? Is there any particular reason for that?
Yeah, because as I went through I have a habit of just updating myself with the article. So I came across this article recently, and I thought about how our textbooks are not having this treatment option as one of like the normal treatment procedure or the protocol. It is not listed in the textbooks. It's not aware to the general public, and it's not marketed widely. Yeah, this is the reason why I chose for a general awareness among ourselves. So that's the reason.
Okay, so I'm expecting you to go for trials and comparative studies as well in future, so that it could be still much more effective to reach the public.
Yes, ma'am.
Yeah, all the very best for your future.
Thank you, ma'am. Thank you.
Thank you, ma'am. Up next, we have DB15. Judges, please note, we have DB15. DB15, you can unmute yourself and start your screen share.
Am I audible, sir?
Yes, you are, doctor.
This is visible, sir?
Yes, it is, doctor.
Okay, sir.
You can start your video also, doctor.
Video. Yes, sir?
Yes.
Now I start?
Yes, you can start presenting. Please go into the slide mode. Full screen mode, that is.
Sir, it is full screen, sir.
It's not, doctor. You need to stop the share, click on share screen, and this time you have to click on window instead of the particular window. Okay, doctor?
Okay, 1 minute, sir.
Yes.
Now?
Now it's visible, doctor. You can go back to the first slide and start, doctor.
Okay, sir. Okay.
You can start, doctor.
1 minute, sir.
Okay.
Sorry, sir, my laptop is not working, sir. I am left, sir.
Just try clicking the next button. Just see if it's going to the next slide, doctor.
Now, sir.
Okay, I want you to click on that enable editing option that you can see in the top, doctor. It's in the yellow band. Yes, that's. Okay, now click on slide mode, doctor. That is the PowerPoint full screen mode. You can click on OK for that, doctor.
Now, sir?
Yeah, much better, doctor. We can start now.
Yes, sir. Thank you, sir.
Today
my topic is drugs used in dentistry. Let's start. Non-steroidal anti-inflammatory drugs. They are aspirin, diclofenac, ibuprofen, ketoprofen. Mostly, we are given diclofenac, ibuprofen. The diclofenac are dosing 50 mg TD, then BD orally, and 75 mg deep intermuscular, and ibuprofen given 40 mg to 600 mg TD as age-wise. Indication: to take post-operative inflammatory condition, pain, wound, edema are indications. And then ibuprofen, that is after tooth extraction, it suppresses swelling and inflammation. Now, contraindication. Contraindication always are hypersensitivity. And the ibuprofen, asthma, peptic ulcer, hemorrhagic disorder. Precaution: diclofenac, asthma, urticaria, and ibuprofen, pregnancy, breastfeeding. Now, the ketorolac, nimesulide, piroxicam also used. Ketorolac is when then the patient come and across the dosing are 10 to 20 mg 6 hours sleep. Indication: post-operative dental pain. Contraindication: peptic ulcer. Precaution: hepatic disease, hematologic disease, asthma. Now, sir, analgesics, antipyretic, or anti-inflammatory properties. Molecules are nefopam, paracetamol. Mostly we are use paracetamol. The doses are adult dose 0.5 to 1 gram TD. Infants are 50 mg. Children 8 to 16 mg, 1 to 3 years of children. 240 to 320 mg, 4 to 8 years of children. 300 to 600 mg, 9 to 12 years of children. Indications: analgesics with poor anti-inflammatory action and traumatic dental pain, post-operative dental pain, etc. Contraindications are for nefopam, that is convulsive disorder, and then paracetamol is renal failure cases. Precaution: angle closure, glaucoma, impaired liver function, asthma, etc. Now we are come to opioid analgesic. They are hydrocodone, oxycodone, tramadol. Mostly we are used tramadol. 50 to 100 mg oral, intramuscular, slow intravenous infusion, 4 to 6 hoursly, children 1 to 2 mg per kg. Indication: mild to medium intensity, short lasting pain due to dentistry. Contraindication: hypersensitivity. And precaution: acute abdominal condition, renal and hepatic disease, etc. Now, analgesic combination. These doses we can use in the clinic. Molecules: aceclofenac plus paracetamol. The dosings are 100 mg per 500 mg, 1 to 2 times daily. Indications: dental pain. No contraindication, no precaution. Aceclofenac plus paracetamol. Dosing 100 mg plus 325 mg. Indication: pain and inflammation. Contraindication: no. Precaution: no. Aceclofenac plus paracetamol and serotonin. Dosings are 100 mg plus 500 mg plus 15 mg per day. Indication: pain and severe inflammation. Contraindication: no. Precautions are no. The same analgesics are diclofenac, paracetamol, ibuprofen, paracetamol, oxycodone, ibuprofen, etc. They are same as 100 by 1000 mg single oral dose with 8 hours observation. Indications are impacted third molar, root canal, dental surgery, etc. Contraindications are hypersensitivity, asthma, coronary artery bypass, and precaution. Precautions are cardiovascular, thrombotic, and GIT, bleeding, ulceration, perforations, hepatotoxicity, etc. Now we are coming to antibiotics. It is most also common drugs in dentistry. Molecules are amoxicillin, benzyl penicillin, cefatril. Mostly we are use amoxicillin. Dosings are 250 to 500 mg TD for 5 days. Indications: dental infection, local wound infections, as well as endocarditis. Contraindications are hypersensitivity. Precautions: renal diseases, glandular fever, pain. Molecules are clindamycin, metronidazole, vancomycin. When we cannot use amoxicillin, then we can use clindamycin, because some patients are allergic to amoxicillin. Then we can use clindamycin. Clindamycin's dosings are 150 to 300 mg orally for 4 times daily. Indication: managements of dental infection that have progressed to bone in those allergic to penicillin. Contraindication: hypersensitivity, pre-existing diarrhea. Precautions: diarrhea, liver, kidney disease, breastfeeding, etc. Metronidazole, it is also most common used drugs in dentistry, because we are know the gram negative and gram positive bacteria present in our body. So if amoxicillin not working, then metronidazole is working the anaerobic and inanaerobic bacteria cases. Dosing: 200 to 400 mg TDS. Indication: orodental infections. Contraindication: hypersensitivity, breastfeeding, pregnancy. Precautions are avoid alcohol, liver disease, etc. Same as vancomycin. Anesthetics: we can use various anesthetics, by most preferable is lidocaine or lignocaine. The dosings are: without vasoconstrictor, maximum dose is 4.4 mg per kg body weight, not to exceed 300 mg, and with vasoconstrictor, maximum dose is 700 mg per kg body weight, not exceed 500 mg. Indications.
Thank you, doctor. The 6 minutes are up, doctor. Judges, please note that was DB15. Judges can now ask questions. Ma'am.
DB15, thanks for the presentation. And why did you choose this topic? Any reason?
DB15, you can unmute yourself now, doctor.
Is audible, ma'am?
Yes, you are, doctor.
Yes, you're audible.
Because, ma'am, I am ex-house surgeon in SSKM hospital for 1 year, and now I am practicing in my personal clinic and one chamber. So this is the most difficult, because some patient, always various kind of patients comes to clinic. Then I choose particular these drugs and use these drugs also.
From where you have taken the references, or which are references you have?
Yes, ma'am.
Considered?
Yes, ma'am. Some KD Tripathi, it is the most beautiful book. Then when I work in SSKM hospital, then some MRs come and they gifted some books, some short books. These books are very useful for preparing this presentation.
Okay. So thanks for utilizing this platform.
Yes, ma'am. Thank you.
Best of luck.
Thank you, ma'am.
Thank you, Bindu, ma'am. Thank you, doctor. As of now, we have completed all 20 presentations. Joby, sir, over to you, sir.
Yes, Joe, Dr. Sivi sir is there. He would like to conclude the session as the leading jury, sir. Can you just see sir and unmute sir?
Yes, sir. I'm doing that, sir.
Yeah. Yes, Dr. Joby, Dr. Binu, and all the participants here. It was indeed a pleasurable experience to be here in this session. Very wonderful. Because, dear friends who have presented the session here, please do listen. I'll switch off my audio due to a lack of range. Dear friends, you have done a great job, because to present in front of many people, maybe online or offline, that itself is a credential. And your attempt and your hard work behind preparing this is great. And I'll request you one thing. please to make a call to the person who supported you in presentation, your guide, now itself. And please to convey your gratitude to them, because all of you are presented well. See, we 4 judges are there. We have 20 papers in front of us. We don't know whom to be selected the best 5 among this 20. But as you know, everyone can't be a winner. Please to forgive us. We are going to have a meeting immediately after this session and going to select the best 5 paper and see you soon on Sunday. Congratulations, Online Dentistry. Congratulations, Dr. Joby, Dr. Binu, Dr. Joe, everyone. A special congratulations to all the participants. And thank you, judges, for your support. Thank you, one and all.
I would like to say one thing, Dr. Sivi, to add on to as an academician and as a practitioner for many years, the thinking way that they have gone, is amazing, and they have put a really good effort. So please do come on Sunday. That's an amazing thing, and attend the conference. It's all free. Please do support us. That is a real motivation to us. Dr. Mindu ma'am, you have anything to add? The other judge ma'am, you have anything to add?
Thank you for this opportunity. And during this days, it's a very blessing that I felt. And all the students also, it will be very encouraging for them during this time, I felt. Thank you.
Thank you. Thank you so much. Now, Dr. Binu, over to Dr. Binu for the concluding session.
Yes, Joby, thank you very much. That was something. That was perfect execution, time-wise, excellent scientific papers, poster presentations, that too considering the fact that they're undergraduates. Excellent presentation. Hats off to all those works. That was amazing. And thanks to the technical team, Online Dentistry, for that meticulous effort of getting everything done by 9 p.m. That matters too. So that was excellent. Guys, thank you very much for coming in. Thank you very much for trusting Online Dentistry. Thank you very much for giving your application, becoming a member, registering yourself, giving your poster, paper, and getting selected and presenting today. It matters a lot because this is an international virtual dental conclave that is pretty new. The new normal is going on. Thank you once again, all of you. Tomorrow, another hectic day coming up, 4 p.m. exact. We are starting with the PG posters and papers. So please support, please be there. You'll get a lot of knowledge, a lot of ideas, a lot of stuff will be there in that also. And by around 7 p.m., we have Dr. Pushparajan sir, the Dean of Lincoln University, Malaysia, coming in and giving us the inaugural address. He is one of the senior most dentists from India, but settled in Malaysia for years together. He's a dean and the chief coordinator for postgraduate studies in Lincoln University. Sir is coming in as our inauguration person. And then immediately after that, followed by another senior most important personality to meet, Dr. George Paul sir. Dr. George Paul sir coming in tomorrow at around 7:30 p.m. 1 hour talk on basic dental emergencies every dentist should know. So if you have a private practice of your own or planning to start a practice of your own, or anybody as a matter of fact, if you're planning to be a dentist, you should listen to such a senior person. His lifetime experience is being shared at 7:30 p.m. Do not miss George Paul sir lecture. And at 8:30, 8:35, we have anterior smile designing, composite, not exactly composite, it's like veneers and the smile designing part by Dr. Ritul Agarwal, who already came into our platform. Hit program with more than 1,200 odd people listened to him. And we decided to bring him down again for the conference day 1. All the way from Abu Dhabi, he is joining. And Dr. Ritul Agarwal is going to enlighten you guys tomorrow with the smile designing part. So these are the two major programs of tomorrow with all the postgraduate poster and UG presentations. So poster and the paper presentations. Thank you one and all. Thank you so much for trusting us and coming in here. Let's wind up for the day. Exactly at 9 p.m. we are winding up. Thank you all. Let's race for 1 second. Let's all race for a national anthem and wind up for the day. God bless. Thank you all. Thank you all. God bless. See you all tomorrow. Good night.